his behavior, if y'all remember, in the video? What's that? Yeah, he's very energetic, he's very dramatic, he's very kind of pacing around. You can kind of tell he's like has a lot of energy, right? So you'd almost say he's activated or maybe a little bit agitated at different parts in the video. Good. Now what would you say about his speech, if you remember?
Inappropriate.
Was it appropriate?
No, it was inappropriate.
Inappropriate, yeah. So sometimes he talks about some subjects that are inappropriate, kind of given society, wouldn't be a recommended societal norm, right? Good. How fast was his speech? Yeah, so he borders on pressure. The way you would tell if he's truly pressured is you'd be trying to interject with more questions, and if you just can't, that's more in line with like a pressured speech, right? So he has this very rapid speech, he's going. Good. And then if you actually, we won't watch the video again, but if you actually remember some of his words, they would actually start to rhyme. He would end one word and start the next sentence with a word that's rhyming, and that's kind of your playing speech. He does it a couple times in the video. He's actually linking his speech pattern together, right? Good. So that's your speech. So now you kind of go into mood. So what would you kind of say he was saying his mood was? Okay, so that's what we're saying. What would he say about his mood? So remember the difference between mood and the difference between affect, right? Mood is what the patient says, it's subjective. Okay? So I don't remember exactly what he said about his mood, but he kind of said he was like frustrated or angry, right? A couple times in the video. So that's his mood. Now what do you all think about his affect? Affect is objective, that's you as the provider making that decision. Nothing. I have no opinions. I don't remember the answer.
Gotta watch it again.
You don't need to watch it again. So kind of remember when we talked about that video, he starts off super nice, but then he jumps to kind of like this hostile state, right? And then he goes back to being nice and appearing tired, and then jumps back into this hostile state. So how would you guys categorize that? There's a word for it. Not bipolar, that's a diagnosis.
Unipolar.
So labile, right? So when I tell you somebody has a labile mood, that's somebody who's jumping from one end of the spectrum to the next end of the spectrum, right? So maybe they're going from a depressed state and then all of a sudden they become happy. Maybe they're going from a happy state all the way back into an aggressive state, right? That's what we're talking about with a labile mood. So this guy, you would almost say he has a very labile mood, he has very expressive features, things like that, right? Good. So that's your A, that's your M. So next we go into sensorium. So what do you guys think about his sensorium? The classic A-No times 3, right? Was he with it? Did he know where he was? Did he know what was going on? What's that? Kind of.
Seemed like we didn't really ask him any questions of like.
We only got one question in, but he actually gave us a location. He gave us multiple cities. He gave us his name, right? So he was oriented to person. He was oriented to place. Time, you could argue back and forth. But this is what classic example of why that A and O, like I know we all love to say it, we all document it, but you can see where it kind of falls apart with some of these patients because they'll be very with it, they know what's going on. But as you start talking with them, their logic train starts to fall off. Yep.
With some of these patients, are they like, do they like switch to that train of thought, or are they like always preoccupied with something else? Because it kind of seemed like he was there and then kind of derailed. So it's
Everybody's a little bit different with how they enter with that manic state, or even with psychosis. Again, psychosis is always going to be in your differential when you're working with a patient like this. It depends on how that brain is miscuing. When somebody's having delusions and stuff like that, or persecutions, the thoughts can take different frames. So it's not unique, it's kind of unique to every person. All right, good. Good, so again, A and O, we'd probably say A and O times 2. You could kind of make that argument for A and O times 3. We didn't really get a chance to do any sort of calculating ability. We didn't really get a chance to do any sort of concentration ability because you just never interrupt, and that's okay. Sometimes with your AMSET, you're not going to get a chance to ask these questions, right? And then when you're documenting, you would just say like, unable to have patient do calculating ability, unable to have patient do concentration ability, right? Good. So that's your sensorium. Now, what do you guys think about his intelligence? Remember, intelligence is your best guess based on the info that you have and how that patient is acting. Yeah, again, I would probably say average intelligence. Like, he's not spouting off crazy stuff to me. He's not telling me about the gravity and how it affects the lunar orbit, right? He's not acting in that childlike state. So again, intelligence-wise, I'd say average intelligence, right? Then we go into thought, and thought's kind of where he falls apart a little bit, right? So when we're talking about kind of that goal-directedness, when he's giving that speech pattern, remember we're talking about those common ones are going to be that tangential line or circumstantial where it swings around. Was he matching any of those, if you remember in the video? What's that? Yeah, good. So remember, we ask a question, what is your name? He goes off on the crazy train, and then he comes back and he actually answers it, right? So that's a good example of that circumstantial speech. And then he also has some tangential in there where he just kind of goes off and starts going down these trains, right? He starts off with Toronto, and then homeless people, and then religious persecution, and then some sort of maybe a sexual harassment or something along those lines, and he never comes back in, right? But we also don't get a chance to ask another question, right? Good. What about, is it logical and is it coherent? Not really. So logical, you could kind of make an argument because it's logical to him, but us as the outside observer, he's not making any sort of logical sense to me, right? And then when you're talking about is it coherent, I would say it is probably coherent speech because you are kind of, he's able to complete sentences, you can follow his train of thought with that, but it's not necessarily logical, right? Good. Now, what do you guys think about his kind of judgment, insight, and we didn't get a chance to do proverbs or comparisons and stuff like that, but they would probably be a little bit off the chain if we did get a chance to ask that. His interpretation would be off or different. What do you guys think about his judgment? Was he showing good judgment? What's that?
To his home standards.
So I would say he probably wasn't showing good judgment in this scenario. He's on the street yelling at a camera, and at the end, if you guys remember, he starts to unblouse, right? Like he takes off his shirt, right? Again, judgment's not all the way there. Do you think he has good insight into his condition? Probably not, right? So if I tell this guy, like, hey, we probably need to go get some treatment, he might start to fight me a little bit on that, or say he doesn't need that. Again, somebody who's in a manic state, being manic is like, apparently, I don't know, I've never been manic, but if I could try one thing, it would be that. It's got to be like one of the greatest highs of your life, right? A patient who is manic, they do not want to come get treatment. They do not want that high to end, because the moment it ends, they're going to drop into a really bad depressive state, and then they have to deal with all the consequences they made while they were in that manic state, right? And manic, you're right on top of the world. So they don't have good insight. So this is why that AMSET, you're going to finally say, like, hey, he is with it. He knows what's going on. He's definitely got some stuff happening, but we need to file an order of protective custody, emergency detention. This guy has to go into the ER. He has to be admitted for inpatient services because he's not having good judgment. We can't trust him not to harm somebody or harm himself. And he doesn't have insight into his condition. He doesn't know that he necessarily needs treatment. So that's how you're using that AMSET on a bipolar patient to finally end up in, hey, they need to go inpatient versus outpatient. Right? So when you guys think bipolar disorder and you're trying to have that picture in your head, this is a pretty good guy to remember, right? Again, I don't know what his true diagnosis was or if there was anything, but he's a good representation of how a bipolar patient could present. All right. Hold on, put my pen in real quick since it's freaked out. Okay. All right, so again, really what we're talking about in this lecture is we're going to go over bipolar 1 and bipolar 2. If you guys can know the difference between the two, that's really the big takeaway from this one, is be able to tell the two apart and make that diagnosis, okay? Good. So a bipolar there, twice. This is a joke from somebody else. I still like it. I think it's a good slide. Lightens up, right? Good. This is from y'all's syllabus. Again, you can kind of see. This is actually outdated. We need to be using the DSM-5 TR, so that's one of my projects I have to do during the break, is update all this stuff. Good. There's your references. So kind of key terms, again, remember that other things can cause the condition. You always want to rule out a substance. You always want to rule out a medical condition that's causing that bipolar disorder. And one of the unique ones is cyclothymia. So cyclothymia is actually a disorder that falls within the bipolar category. It's a hard diagnosis to make And essentially what you have is you have a patient who over the course of a couple of years is constantly bouncing between hypomanic and depressive. Normally a manic patient for bipolar 1 or 2, you're talking 1 to 2 to 3 episodes in a year. They have greater than 4, we consider them a rapid cycler. For cyclothymia, they're constantly bouncing between the two. They have multiple episodes. I was talking with a patient, we thought she was right there between having borderline personality disorder and cyclothymia. And the way she would describe her emotions, it's almost like somebody was flipping a switch constantly. So she'd flip a switch and be super happy, and then for no reason she'd flip a switch and be sad and depressed, and it would happen throughout the year, right? And that's where you kind of, these conditions also kind of start to mesh together, is that time frame, how quickly somebody's switching between their conditions, right? Cyclothymia, it's a pretty interesting one, but we're not going to go super in depth with that one. Because again, it is a harder diagnosis, right? That's kind of your description for that. Okay. So really what we're talking about today, we're talking about bipolar 1, bipolar 2. The quick and easy breakdown between the two is this one is the more severe form. This is somebody who's going to go into true mania, and this one is always going to end with a hospitalization, patient being in jail, or the death of the patient, right? That's how severe this state can be, right? Bipolar 2, it takes a lot longer to make this diagnosis because they don't necessarily end up in a hospitalization. They go into like a hypomanic state where they're kind of sleeping a little bit less, they're more active, they're more productive. So sometimes the patients don't even know what's going on. They're like, yeah, I was just I just have these bouts during the year where I'm just super productive and I don't really need to sleep. And then they kind of dip in depression, where they're kind of be sad and upset. That's usually where they're coming to see you, is they'll have these depressive states that last throughout the year. And you have to kind of do that deep dive, talking with them. You usually have to see them a couple times, so we're usually delayed in making a bipolar duty disorder diagnosis, often by a year or more. Right. So your classic mnemonic when you're talking about anything within the bipolar category is going to be think fast. So when we're talking about the criteria that needs to be met, they have to have some of these, right? You don't have to have all of them, but we're going to get there in a second to the number that you need. Is usually going to be like 4 of these symptoms present or 3 of these symptoms present. And you're talking about distractibility. So remember, they easily jump from topic to topic. They have a hard time finishing what they're talking about, right? They're easily distracted. Impulsive. That's that poor judgment. They make really bad decisions. These are the people who they were happily married, they have kids, and now all of a sudden they go and they sleep with 5 different people, unprotected sex, right? They're just in this manic state. They're making bad decisions. They've never touched a drug in their life, and now all of a sudden they decide to go and try cocaine, methamphetamines for the very first time in their life, right? They're making poor decisions. These are the people who they have like a huge savings account, and all of a sudden they just lose it. They fly to Vegas because they're still with it enough to make those decisions. No one's going to stop them. And they spend all of the money in their retirement account, right? All within that manic state, all within a very short period of time. That's what we're talking about with that impulsivity. Grandiosity, this is where they have a very, very inflated view of themselves. They are the greatest thing in the world. They are awesome. They're amazing. They can make no mistakes. They are better than you. They can tell you how to be a doctor because they themselves know everything within the cosmos, right? Flight of ideas, this is where they have those rapid, multiple thoughts that come out constantly. So if you kind of remember that Joe Spiros guy, he has these clear thoughts, but he's jumping like constantly there. There's multiple themes that occur within there. That's a good example of flight of ideas. Activity, so again, that agitated state, they're very amped up, they're ready to go because essentially they're high. Now it's a natural high, but they're high, right? Sleep, this is a big one. Normally, you guys need to have 7 to 8 hours of sleep per night. The human body needs sleep to reset. For these people, they're gonna drop to like 2 hours of sleep, 1 hour of sleep, and they're gonna be, the next day, be amazing, right? Like that's not normal. If you're only getting 1 to 2 hours of sleep, the next day you are dragging, almost in like a drunk or hungover state, right? But they're going to be perfectly fine. Talkativeness, that's that pressured speech. They're going to be very, very rapid. It's hard to interrupt with them or talk with them, right? So, a good example of this. I was taking care of a patient on 6T, and this is the manic dentist, right? So she finally, command brings her in because she had been this actually like super productive at work. knocking out a bunch of exams and stuff like that. Like Amanda's like happy, like, hey, we're getting above schedule. This is awesome. But she wasn't sleeping, and all of a sudden she kind of started to have these weird thoughts and expressing these weird ideas. So she finally brought in for a command eval, and we're talking with her, and she is very animated and talking, and all this stuff is going on. You're like, okay, so maybe she's just a really happy person. That's fine. But then she started talking about how she could replace organs, and she needed to go see her dad, right? So finally, we admit her. And then what they do is they have a group milieu. So you're gonna always go and be within a big group of everybody else who's on the floor. It kind of helps with that healing process, recognizing there's other people that's on there. So what was happening was while she was on the floor, because it takes a little bit of time to come off that manic state, that she was literally sitting in front of the group of probably about 15 to 20 other people, and she was essentially giving TED Talks about how to succeed in life, how to like be the be-all you can be, how to be an amazing person. And let me tell you, they were good. Like, I was listening to them and I was coming out there motivated. I was like, man, that was a really good talk. She's animated, she's fun to listen to, she's talking about how to be the best person you can be. Like, and then she kind of goes off the crazy train and talking about how she's Jesus. But otherwise, it was great. Good. So, this is your kind of key breakdown between mania and hypomania. Remember, if it's mania, it's going to be bipolar 1. If it's hypomania, it's going to be bipolar 2. Right? Elevated mood for 1 week, or the moment they need a hospitalization. If they go inpatient, it is automatically bipolar 1, right? You guys will see with this one, they only need that elevated mood. Next thing they pay attention to is the time frame. So remember this, 4 to 6 days is hypomania. If they're going greater than 1 week, now all of a sudden it becomes mania. So again, I know somebody, I think you were asking yesterday, is everything 12 months? We would never make it that easy on the student. We always want to switch up time frames. We have no consistency with it, right? We make it hard on purpose. We suffer, therefore the next generation must suffer, right? Then you only need 3 of these. So of that dig fast, you only have to have 3. You can have more. You can have all of them, but you only need the 3. That's the same for hypomania. This doesn't change, right? And then it has to be severe. So again, that severe is where they're quitting their job, they're leaving their family, they're doing something severe, they're ending up as a hospitalization within the police department. That categorizes as severe. Not severe, again, they're still able to perform their job, they're not needing to go hospitalization, they're just more active than usual. That's why hypomania is a harder one to make that diagnosis in, right? And of course, is why we order a drug test on everybody who comes in the ER for the psych concern, because we always have to rule out that substance, right? So anytime, as part of your workup, if you're in the ER, a person comes in, you're going to have to call psych, get a urine drug screen, just go ahead and order it now, that way it's already done. There's going to be some other stuff that goes along with it, that's the big one. Okay. Now, that's the main key points highlighted right in there, okay? Good. So again, when you're talking about the criteria, this is now from that pink box. This is just another way to look at that information. It gives you a little more clarity on what's going on. Right, at least 1 week for hospitalization, lasting 4 to 6 consecutive days. Don't get those time frames mixed up, right? So if I tell you that somebody's had lack of sleep, they're super talkative, they have grandiosity, and then they went inpatient within 1 day, is that going to be mania or hypomania? Mania, right? Because again, needing that hospitalization, they now meet that criteria. It's now severe enough. Good. There's your dig fast, and this is how it lines up when you're talking about those. Again, it doesn't line up perfectly in alphabetical order, but you guys can make those connections between the two, right? Good. This is another way to look at that dig fast. Again, some people are visual learners. They like the visual aspect of it. So this is a good example of somebody who has mania in character form, right? So that distractibility, indiscretion is kind of like that impulsivity, grandiosity, flight of ideas, activity increase, sleep deficit, and talkativeness, right? In adults, usually that sleep deficit is going to be present. That's one of the big ones. Believe it or not, in kids, it's the opposite, right? In kids, it's actually that grandiosity. If you're talking with like a 10-year-old and they're acting like they're on the same level as you, that's a pretty good sign that something else is going on, right? But don't worry, I don't think we're going to go in with kids on this lecture. I really kind of want you guys to focus on making the diagnosis in adults, because the CAP psychiatrists, child and adolescents, they struggle making this diagnosis in kids. It's a hard one to make in that pediatric population. So that's kind of more of a specialty high-end stuff. Even at my level, I refer out to CAP because that's what their training specialist is. So for you all, I really want you to nail the diagnosis in an adult population. Good. Again, this is going to say kind of like that same information over and over again. So if they have a manic episode not related to something else, diagnosis of bipolar 1 can be made. Again, these people, this is a big one down here. Again, you're high right now, right? You're feeling awesome, you're feeling amazing. They don't want that to stop. They're going to be very resistant to treatment. You're still going to offer them. You always start with the least offensive and then kind of go from there. So you're going to try and talk them into just taking a medication, right? Taking an oral pill, that way they can get under control. We have their consent. Even though they're in this manic state, they can still make an informed decision and consent to treatment. It's always going to be a big theme in psychiatry is we want the patient to consent to treatment. Now, if they can't consent, then we're going to go to that next level where maybe now we need to go with an IM formulation and we actually need to forcibly give that to them. There's always going to be more paperwork that's done with that because now I have to violate that patient's rights. I'm violating their autonomy. So you always kind of slowly go up the escalation ladder. If they're a super danger to themselves, they're a danger to the staff, then we kind of jump ship and we go straight to we need to bring the person down, calm them down. That's where we use some of our heavy hitting medication, right? Next thing, don't ever forget patients who are in a manic state, bipolar, they're at an increased risk for suicide. That's one of the criteria we can use to bring them in against their will because I can't guarantee their safety. And it's not just in the manic state. When they go into that depressive state, their suicide risk stays high because what happens is they're now thinking clearly, they know what's going on, and one of the big issues is they have to deal with all of the repercussions and the choices they made while they were in that manic state, right? Just because you lost all your money gambling and you were manic, Vegas is not going to give that money back to you, right? If you cheated on your family members while you were in a manic state, you can't go backwards from that. Like, yes, maybe the family is going to be understanding, but you can't guarantee that, and it's a significant wound that's going to have to be healed, right? If you decide that you want to do IV drugs and you pick up HIV or AIDS because you did it just the one time, you had really bad luck, that's now a condition you're dealing with for the rest of your time. Those choices have a repercussion that you have to deal with in that depressive state. Good. That's your diagnostic criteria. Again, one manic episode is really all you need. You only have to have the one. That's why you want to get a good history of what's going on with them. That's where, again, hospitalization kind of makes it super easy. So, we'll learn about schizoaffective disorder. That's going to be in the next block. So the one thing I'll tell you guys on the test that's coming up, if you see an answer choice that you've never heard before and we haven't covered it in this block, it's because you didn't study well enough. No, so if I give you a scenario where the patient, I'm telling you, hey, this guy has bipolar disorder, and you see like schizoaffective disorder, alcohol use disorder, bipolar disorder, and you go, well, what's schizoaffective? We haven't been taught that. Please don't pick that decision, right? Some of you will, and that's okay. But if you don't know it, and it hasn't been taught in these blocks, it's probably not one of the correct answers because I can't test you on it, right? But they are distractors. They are part of that differential diagnosis. And we'll learn about this next time. Good. So this is your differential diagnosis when you're talking about bipolar disorder. Because there's a lot of specifiers that we haven't really got into. That's why psychiatry exists as a subspecialty. And if you guys really want to know more about this, I would definitely encourage you guys to go to one of the fellowships for psychiatry. But MDD can actually have a psychotic state associated with it. You can actually become so depressed that you become psychotic, right? Anxiety can be so severe depending on the person and what's going on with them that they now can't leave the house and they almost enter like this kind of state where they are feeling like they're persecuted and everybody's against them because their anxiety is so bad and so through the roof, right? Panic disorder, again, panic disorder is just you're walking down the street and all of a sudden you get this overwhelming sense of dread that something's going to get you and it's completely crushing. So it's so sporadic and this randomly happens that it can kind of mimic bipolar disorder, right? Because a person can be perfectly fine and then they have a panic attack. Good. Substances are going to be the big mimicker. And substances cause all crazy things. Like meth is a hell of a drug, y'all. Like it does some crazy stuff. Even marijuana now, when you're talking about like 90% THC that's in a dab, like we were causing psychotic episodes just with marijuana, which you've never really seen before. And a personality disorder, one of the ones that we're going to learn about that loves to mimic these is borderline personality disorder. They have these huge inflows of emotion. They can almost mimic a manic episode, but they're very erratic and it's all over the place. But again, it can mimic bipolar disorder. Good. Big thing with bipolar 2, one of the other big switches with this is they have to have a hypomanic and they have to have a known depressive episode, right? Because again, they never really go inpatient. If you guys remember back to mania and bipolar 1, they don't necessarily have to have that depressive state to make the diagnosis. You can make it while they're manic. With bipolar 2, they have to have a clear episode of both. An episode of hypomania, and then it goes into an episode of depression. Then you can make that diagnosis of bipolar 2. That's going to be one of the big differentiators between the two. And for the depressive episode, there's no difference between major depressive disorder and a bipolar depression, right? That SIGI-CAPS criteria remains exactly the same. So a depressed person who's bipolar is going to present the exact same way. That's where you need to get that good history of what happened before they became depressed, right? What is your time frame for depression? 2 weeks? Good. What was your time frame for persistent depressive disorder? 12 months? 2 years, right? Remember, your time frames matter. Good. All right. Again, that's your criteria for the pink box for bipolar 2. This is where it never rises to the level of a manic episode, right? Manic being that severe hospitalization greater than 1 week. Remember your time frame. Hypomania, 4 to 6 days, okay? Criteria again, that's going into that pink box. If you guys like the pink boxes, you can definitely use that to learn and read from it. It offers more information, a little bit more detailed, whereas my slides are a little bit more condensed, kind of trying to hit the highlights. Okay. There's your differential for bipolar 2. Again, very similar to bipolar 1 as far as the conditions go. There's a couple unique ones that are in there. ADHD in kids. All right, so just kind of this information is a little bit older, but essentially bipolar disorder, you're talking about 5% of the population can kind of hit that roughly 5% for bipolar 1 and bipolar 2 of the U.S. population can have this disorder. It's not a big segment of it, but it is one of those actual psychiatric emergencies where we need medication. This is a disorder that has to have meds. They don't really get better with therapy, right? And then if you look at the population, 18 to 29 is usually where you're going to have your first manic episode or your first hypomanic episode. That's the population that we as the military tend to recruit from. That's why a lot of times you'll see these kids and they'll have their first break, they'll diagnose them, they'll go inpatient, then we med board them out, so you don't really see them for long-term management. A lot of times we take care of them during that first episode. Good. So your medication management, valproic acid in the U.S. is kind of considered that first line. It's starting to fall out of favor just because it has these other effects when we're talking about teratogenicity. But it's a good med. All the options, it's like one of the good, worst options essentially, because they all have some pretty negative side effects associated with them. Lithium is another great option. I actually kind of tend to prefer lithium a little bit more, especially if that person has good insurance. They kind of have a reliable support network that can actually kind of manage the follow-up. Because lithium also has this added benefit of helping with suicidality. So if suicidality is one of the key themes of that person's bipolar or depression, in that scenario, I actually like to go with lithium over valproate. Valproate doesn't have that indication for helping with the suicidality, right? Only lithium does. Right when they're in that manic episode, that's where we have to hit them with the antipsychotic first. So usually we're giving them an antipsychotic second generation. We're giving them a benzodiazepine. That gets them calmed down, gets them out of that agitated state. But you have to start a mood stabilizer. If you're discharging a patient who's bipolar without a mood stabilizer, you're kind of doing them a disservice. You're not bordering on malpractice, but you're getting pretty dang close. Because there is some argument to be made if you're a psychiatrist that if they're responding really well to the antipsychotic, you can just continue on with that. It's not common. I wouldn't recommend it, but there are some psychiatrists out there that are doing that. Right? So long-term management, again, they have to be on a mood stabilizer, and that mood stabilizer is going to continue on throughout the rest of their life, right? Because mania, bipolar disorder, it's not a diagnosis that goes away. It's just a matter of time before they have another episode. You're just trying to buy as much time as possible. Usually what happens is that patient has gone a couple years without having a manic state, and they're doing really well, right? But these meds are a pain in the butt to use. They have nasty side effects. So they stop taking their medication because they're like, no, I'm healed, I'm fine. And they'll stop the med, and then they go straight into a manic episode within a few months to a year, right? That's usually the theme that happens. Yep.
Talking about doing like some of the more mild, I didn't say mild, but some of the less out there bipolar episodes of mania.
Mhm.
Do you have a preference in your second generation, like Geodon versus Droperidol versus?
No, you're going to use what's on formulary. If I want to continue the med over into, if I want to carry the antipsychotic into their depressive episode, because I know that depressive episode is coming, I wanted to use one of the ones that has an indication for MDD, right? What's that?
Like an olanzapine.
Yep. So like the penes are really good, like aripiprazole, olanzapine, they're pretty good for that. But also remember when you're talking about your antipsychotics, you want one that has the most options as far as route. So if you can, you want to use one that's going to have a LAI or long-acting formulation. Because then I only have to give it once a month, or I only have to give it like once a year, depending on the drug, right? So I'll start them on the oral, and then as soon as they're stable, I know they tolerate the med well, I'll convert them over if they're willing to the long-acting injectable, because my compliance is going to be significantly high, right? Good. I remember with that lithium. So remember, with this drug, you do have to remember your plasma concentration, because that's the big one with this. They have to stay within that window. And anything that's going to affect that patient is going to knock them out of that window. So usually you're talking about like every 6 months you're grabbing a lithium level, or if they're coming in and they're sick, or you made a medication change, or they're acting a little bit different. In those cases, I'll grab a lithium level early because I want to see where they're at, right? Good. Again, you guys have seen this slide. This one, they're both first line. You kind of tailor it to the patient. But again, kind of in the U.S., we tend to favor valproic acid. It's a little bit safer compared to the lithium. And there's your kind of your drugs that we really kind of like to use. I like olanzapine. Aripiprazole is another one that we commonly can't use. It's newer on the market. Good. Valproic acid, first line treatment. This is coming from this is from Current. Good. Current is an okay book. It's great for primary care level. I think it's fine for that. All right. So that's kind of like your quick down and dirty for bipolar disorder. Remember, greater than or one manic episode. You can have the depression or a hypomanic. Bipolar 2, you have to have a hypomanic and you have to have depression in order to make that diagnosis. Good. All right. We kind of covered all of this. I don't think we need to say any of that again. Any questions about bipolar disorder? Well, yes.
So for this bipolar disorders, do they have to like get triggered by certain factors like people, events, or?
No, not necessarily. A lot of times there is an inciting event, but you don't have to have one. Yeah, so they can just enter a manic state. A lot of times there might be a triggering event that kind of sets off the emotion, but you don't have to have one. Is there a question on that? Yeah.
Just to clarify, so for bipolar 1, you don't need to have an depressive or manic episode?
Correct. So for bipolar 1, the biggest thing is that manic state. You can diagnose it based off one manic episode. You don't have to have the depressive episode to make that diagnosis, right? Because it's so severe. With bipolar 2, because it's less severe, you need to have the hypomanic and the depressive episode. Don't get mixed up. Someone who has bipolar 1, they will hit a depressive state, but you don't have to wait for that depressive episode to make the diagnosis. Is that clear enough? Okay. All right, let's take our 10-minute break, and I'll pull up the next slide. Yeah, so because you work in the hospital or something like that, those usually quick treatment. So that's a great question, right? So it depends on the So if you already see people that they have bipolar disorder, I'm not gonna say they're gonna get sick. So a lot of times they'll come back and see you, and you'll notice like, hey, they're putting them on, I need to be aware of.
Mainly heart attacks are making heart damage itself.
And that's what right? Oh, that's kind of abnormal.
Well, you do it all together, so it.
You don't need to be on here every time you out of bed to a psych. Right? You have a concern that you need to adjust. In those scenarios, like, just do a quick consult, like a telephone call, like, hey, I have this guy, I'm just lithium level came back and it's low, I just want to increase it for a little bit. Can I do that? That's where we can say, oh yeah, go ahead and pump the blood, or check 6 months on. Hey, or hey, send them over to us, like.
So I do elevated and HDL because HDL takes it from the tissue to the like out. LDL takes it from the liver to the tissue, and that causes like atherosclerosis, like flattening cells. And total cholesterol. But what's making the total cholesterol? HDL or
So over 1 week or hospitalization.
And you have, you have a foot like for me, like, I know they joke about like especially this day.
It's that time frame that makes the difference. Because the moment they hit 7, now when if you're only averaging 20, that's what happens to me. So they tell me, oh yeah, I never know when you got something like 5 months. You're like, yeah, that's like that's like yours. So I make sure we have a good time.
Oh yeah,
No. Yeah.
Sweet dude, you look like he had 2 brain cells. Like,
Not in a hospital scenarios, 7 days, right? But if you're only at 1 day that you're in the hospital, like you don't want to kill So remember, I always have to have both. You have to have a hypomanic episode, and you have to have bipolar. Yep, bipolar 1 is the ill that when you have they don't need to take that thing. That's right. Yeah, so when you're talking about media and bipolar disorder, patients aren't going to go into another episode. We're going to talk about what it is. Having more than one. And that's where we start to go into, well, this is something else. It's like that. It's actually personality. It's actually, I mean, you're not supposed to go for that. Those are two different diagnoses. Right? So you gotta remember that criteria. So hypomania only 4 to 6 days is how long the symptoms are lasting. And then you have to have that right? Those kind of stuff like that. Because the moment it goes over 7 days or hospitalization, then it becomes mania bipolar 1. That's what Yep, and then, but you don't go backwards, right? Once they have a bipolar 1 diagnosis, that's what we're doing. Okay.
Oh.
I'm always going to go with the more severe diagnosis, but again, that's just a dangerous thing. I don't want them to miss that diagnosis. I don't want them There's always going to be a risk, right? That's why you have to know your criteria. That's why you need to episodes or it takes so long to get bipolar 2 diagnosis. We want to make sure we're actually good. But it's bipolar 1 is more 35 and people that are hospitalized on that time frame no longer. What's going on here? I have to do that basic, like, are you something actually? Bipolar is just a simple thing. It's not a it's actually a balance that I have to What's that? This is everything. Yeah. So in reality, you can use both of them. They don't always depend on what the device is.
You know what, Alex? I think you're doing a great job. I would promote you ahead of peers.
Oh, that's the part.
I'll do it right now. Done.
Yeah. You just made that up. Oh, I see.
Yeah. So you always want to take care of that acute episode first. So if they're when they come in, usually have to start on the psychotic.
Me too.
They also starting to because it visualizes takes a little bit longer to take the end of kind of right? Then once I have to stabilize, I'm kind of getting that discharge. That's why I have to be able to want to continue the psychotics. I want to I know what it means. That's what's going to
Let's look at this. People who play the lottery are not normally physically play the lottery. There's annual
So patient comes in with panic, they take it with a secondary psychotic, they go to police pressure, then go to first ends up to be able to yeah, if I'm not worried about safety, I'll be off. So that makes sense.
which one is going to be up?
You were actually
We don't really know about 100% of what the actual essentially you have to do the brain is like three tasks. Right? What we think is going on with it is that neural signals are firing really fast. You get different channels. The axonal signal is whereas really the axonal signals are firing really fast. Using that's because you have which is why we're not that's why I have to have Again, that's kind of like a rush. Just that's where I want to
hearing on this okay, it's the preliminary hearing and then we're gonna have that secondary preliminary hearing. Preliminary hearing this night. But then now they have a date in-person public hearing on 16th January. I've seen the do it, sir. I don't know our business scene. Yeah.
I think these are the three that I want, and let me see how I do it. I'm glad that you guys believe in me. I don't know if I believe in you.
Like every other
Yeah, I guess that's probably about as good as we can do. It's so big for this.
Oh yeah, should be able to do that.
And we'll just go with that. Okay. So, we're going to talk about our eating disorders and stuff like that, right? So, eating disorders, the big three that we're going to talk about is we're going to talk about anorexia nervosa, we're going to talk about bulimia nervosa, and then we're going to talk about binge eating disorder. There's a couple others that fall within that category, but those are the big three that you all in the primary care sector really need to know about, right? And believe it or not, in the military, because we have such a heavy focus on weight and appearance, we do actually have a little bit of a problem, not so much with anorexia and bulimia, because they tend to be so severe, but with binge eating, right? A little bit with bulimia, because you kind of carry a normal body image with that. But it is kind of like the untalked about issue that we have with the military, because we have such a heavy focus on appearance and weight, right? Like if I bring young people in and I tape them every 6 months and they call them fat, you're gonna have a little bit of repercussions sometimes, right? Whether it's fair or not. So, character that I want you to kind of keep in your mind when you're talking about anorexia, right? This is kind of like the best, most appropriate one I can come up with off the top of my head. Who here has seen like the old Hercules cartoon?
Oh, you know.
Good. Okay, cool. So you guys remember like when he loses his power and he has to go down into the underworld to get his girlfriend and bring her back, right? How does he look kind of in that scenario? Emaciated,
Like he's
skin
a
and
vampire.
bones, right? How do his eyes look? They're very sunken, right? And then how is his movement? Very slow. Because again, you're in a caloric deficit. You move very, very slowly. You have kind of slower emotions. Your cognition slows down because it's not getting enough nutrition. So when you're thinking about anorexia specifically, it's somebody who's emaciated, somebody who's very slow. They don't have quick reactions, right? But are they oriented to person, place, and time? Yes, right? Are they having clear and logical thoughts? Are they able to communicate with you and talk with you? Yes, they are, right? Are they showing good judgment? No, not really, because anorexia is going to lead to your death, right, in the long run. So that's kind of it. But are they showing good insight into their condition? Maybe, 50-50, right? Like, a lot of times these patients know what they're doing is bad once they've been in treatment for a while. It depends where you catch them in the treatment algorithm. A lot of times when they're first starting out, they don't think anything about it, right? They're just concerned about their body image, like all my friends are skinny, I want to be skinny, right? But then once you make that diagnosis, they have some hospitalizations, they know what's going on, but it's a tough diagnosis to fight, right? Because it's lifelong. And it's kind of almost a mental condition with that, where that person just have to be in that state. So it's hard to make a correction, right? So when you're thinking in your mind for your visual learners about how an anorexic patient looks, just kind of remember that Hercules character from when he loses his powers, right? And that's how they're going to act as far as like being very slow, their cognition is going to be very short. Maybe they have insight, maybe they don't. Their judgment's going to be clouded, right? But they're still having coherent thoughts, they're still very logical, their speech is going to be rapid and fast, not having those flight of ideas, things like that, right? So let's get into this. Again, there's your syllabus going forward. So a couple of disorders that also fall into this. So pica, that's where you're eating something that has like no real nutritional value. A common one, thinking along the lines of like dirt, clay, coins. You can actually have hair that you're eating. Or you can also, a good common example is ice. Because ice has no nutritional value, but you're just kind of like eating it, right? That's your pica. Rumination. Rumination disorder, think along the lines of a cow, right? So what does a cow do? They eat their food and then they regurgitate it, they eat it and swallow it again. So a lot of times you see rumination disorder in kids, right? It's a control mechanism. If you think about a child, they don't really have a lot of agency or control in their life. They're kind of, everything's dictated to them by an authority figure. So their food is one of the things that they can control, right? Same thing with ARFID, so avoidant restricted food intake. So your kid that will only eat the dinosaur chicken nuggets, that's kind of what we see with ARFID, right? They have all the food available to them, but they will only eat a select amount, and it becomes a disorder when that now is having a nutritional caloric effect and they're missing their milestones, right? Because they've restricted their food so much to things that they're not getting their fruits, their veggies like they normally should, right? So we tend to see this more, these two, more in kids than we do with adults, right? And then kind of, if it doesn't fit into one of our categories neatly, we always have that unspecified that we can go with, right? So again, big three when you're talking about these eating disorders, right? Restricting the amount of food that they're eating, leading to a low body weight, maybe. Intense fear of gaining weight or becoming fat, that's pretty consistent with all of them. And then disturbance in self-perceived weight or shape. And this is not that they're upset that they're skinny, this is that perception that maybe they're too fat, or they put on too much weight, or their muscles aren't big enough, right? That's what we're talking about with the perceived disturbance in perception of self, right? Restricting type and binge eating type, this is what we're talking about with anorexia specifically. So you can actually have anorexia without having the binge and purge. That's kind of a specifier that's associated with it. A lot of times the biggest one is the restricted time. That's usually what we see is they're just not taking food and they're doing activities to limit that food. That's where that person is walking around with a giant jug of water and they're drinking all that water to artificially fill them up so that they're not hungry. Okay. There's your diagnostic criteria from the pink box. Okay. Kind of see restriction of energy intake, intensity of gaining weight, disturbance in the way in which one's body weight or shape is showing up, and then we have that restricted type and that binging and purging type, which are specifiers for anorexia nervosa. Right? What you have to have in order to make the diagnosis of anorexia is you have to have a low BMI. So when you are evaluating a patient and you're worried about it, if you don't have a BMI, you cannot make the diagnosis, right? It's part of the criteria. I have to have this, right? And this is what allows me to put them in a category of is it mild, moderate, severe, or extreme. So you need to know the BMIs that are associated with the anorexia and the level that it's going to be at, right? So it's a good practice anytime you're seeing your patients, grab a height, a weight, and if you're dealing with psych meds a lot, try and grab like a waist circumference. Because a lot of times the meds that we give, they tend to cause truncal obesity first, and then it kind of spreads throughout. Okay. This is usually starts in your teenage to young adulthood. It really usually doesn't start over the age of 40. It's usually a compensatory mechanism that's carried forward with that past that point. It's a lot of times it's associated with other disorders, especially anxiety or obsessive compulsive disorder. So a lot of times we see these as comorbid conditions. A lot of times patients will have multiple. They usually don't just have anorexia. Muscle minerals, if they have an actual function. I've met many people that have anorexia, and they're still functioning to a point. They're still hanging out with friends, hanging out with family. They still have a job. They're just not as active as they could be. And then sometimes the family starts banging on them about it, and then they start to isolate. They start to pull away because people are noticing what's going on with them and making a point to point it out, right? This is the big one down here, right? So because you are in that caloric state, now all of a sudden your electrolyte panel is going crazy, right? Now you're having potassium that's going through the roof and you're worried about having arrhythmias that are starting to show up, right? Or this is where you run into that refeeding syndrome. It's where we start to correct what's going on with them and we don't properly manage their nutrition, and they can actually have a refeeding syndrome as I'm correcting the condition. So you always have to worry about your lab panels, and you always have to get an EKG on these patients so you can monitor what's going on with them when you're not causing an arrhythmia. Treatment-wise, anorexia is a very difficult diagnosis to treat. It's hard to turn somebody around, and a lot of times it's something they're going to struggle with for the rest of their life, right? Definitely 100% they need therapy. The big one is going to be cognitive behavioral therapy. That's our building block. And a lot of our other specialized ones we incorporate after that. A lot of these patients, they actually have to go to an outpatient program or an intensive outpatient, and they need kind of that set care where they're monitored by a specialized team, usually over the course of a few months, right? That's how difficult this can be to treat. Medications, we still use them, but in general, you're not really treating the eating disorder with the med. You're treating the comorbid condition. You're treating the anxiety that's associated with it. You're treating the OCD that's associated with the anorexia, right? That's really what the med is doing. It's not going to make them eat more. And that's where you actually have to be a little bit careful with your meds and the side effect profile, because in a perfect world, I could give them like mirtazapine and Paxil, because there's that chance that it can stimulate their appetite and they'll want to eat. But you have to keep in mind if the person's super concerned about their weight and their appearance, that can make everything worse because now you're making them gain weight when they're not mentally ready for that yet, right? As opposed to if they're already in an anorexic state and now I give them Wellbutrin, well, Wellbutrin can worsen their weight loss, right, and give them an artificial anorexia. And now I'm fighting the therapist and making my condition worse. So the med management can be a little bit tricky when you're talking about an anorexic patient, right? And then you always have to worry about the heart in these people because of that caloric state and the electrolyte panel is going crazy. So a C-tau impairment is not one of the ones you want to use in these patients because it has that cardiac warning for it, right? So again, that's where med management can be a little bit hard. Hospitalization, these patients commonly end up in the hospital because they've gone hypovolemic. but it's actually hard to keep them in the hospital against their will because they are with it, they understand the repercussions, they know what's going on, they have full agency of their body. I was taking care of a patient over on the inpatient side as I was consult liaison. So she was in a hypovolemic state. When we were talking with her, she was straight up eating only like a Reese's Pieces cup about once every 3 days. And the rest of the time she was downing water to keep herself full, right? So that's her only nutritional value was a piece of candy. So she was on the inpatient med team floor, and they were starting parenteral feeding for her through the IV to kind of slowly correct this imbalance, right? But this patient, I think somebody was asking me the other day about prolonged grief disorder and PETS count. So this patient, she had a very strong connection with her dog. That was really the only constant that was in her life. So she had gone inpatient to the hospital. The dog sitter was like, hey, I can't watch the dog anymore. Like, I have to just leave the dog at your apartment. So now the dog was at her apartment by herself. She legitimately went AMA against the hospital when she was in a caloric deficit, hypovolemic, and an electrolyte imbalance to go home and take care of her dog, right? So the med team called us, so we go down and we do our psych eval, because the biggest thing we're going to determine is if you have agency, if you have capacity. And our basic assessment was like, she's fully has capacity, she understands she could die if she leaves the hospital, she has good insight into this condition. We can't force her to stay. So we had to let her go AMA to go leave the hospital so that she could go take care of her dog. So she went home, and then she actually came back a few days later, back into the hospital to restart treatment, right? So again, these patients, they understand what's going on with them all the time, but it can cause some significant issues, especially when you're worried about the patient's safety. Force feeding, you'd have to be in a pretty bad state for me to go ahead and force feed you, because that means I've determined that you have no capacity. And I am now making medical decisions for you. In the psychiatric world, we try to avoid that as much as we can. Because that's a huge violation of a person's rights. Whether that's a good thing or a bad thing, I'll leave that up to y'all and your own personal political beliefs. Great. The goal is always going to be to get them back to a normal body weight and kind of reduce the symptoms that are associated with it. That's always going to be the goal of the treatment. Sometimes we're successful, a lot of the times we're not. Right. So that's anorexia nervosa. So remember, with anorexia, they have a low body weight, right? And then it can be restrictive, where they're just not eating, or they have a purging behavior, okay? Now we're going to go into bulimia nervosa, and the category is going to change a little bit. With bulimia, they don't have to have a low body weight. They can actually have a normal body weight. But with this one, there's going to be some sort of purging behavior associated with that, okay? So a big one with this is they actually are going to have a binge episode where they just overeat to the point where they're full, they're uncomfortable, and it's almost going to be painful, right? And it's almost, again, this lack of control where they just can't stop themselves from eating, right? You go to a buffet and you legitimately just keep going back over and over again, and then you get the meat sweats, you're like, why am I still eating? That's what we're talking about when you have no control over the situation, right? And then they have that inappropriate compensatory behavior because they've overeaten, they know it's bad, and now they're going to do something about it. So, what do you guys think are some compensatory behaviors? What's like the classic one everybody thinks about? Purging, right? So vomiting, right? But it can actually take multiple other forms. So, what do you guys think are some other ways a patient's going to purge or get rid of all that weight? Correct. Yeah. So actually, if somebody overeats and then they're exercising for like 4, 5, 6 hours a day to get rid of that, and then to the point where they're hurting themselves, that is a purging behavior, right? I heard somebody say laxatives. 100% your patients can be abusing laxatives to get rid of all that weight. They're basically forcing through their diet, right? So it doesn't just have to be vomiting. It can be other forms. So don't ever just get tunnel vision and then, well, he didn't put in here the patient's vomiting and get rid of it. Like, I can use other forms when I'm writing my test results, or your patient's going to present with other things. Good. There's a pink box criteria. Again, kind of more information for y'all. If you want to go in there, it adds a little bit more. Good. Treatment for this one. Again, we still want to have that therapy session, so they're still going to be going to therapy, but we do actually have some meds that have an indication for bulimia. With the big one being Fluoxetine, right? Make sure you don't mix up fluoxetine with fluvoxetine, but it actually has that FDA indication to help manage bulimia nervosa. It's kind of one of the things that makes that drug unique. What I will tell you guys, just kind of offhandedly, is when you're dealing with eating disorders, obsessive compulsive disorders, anything that falls within that category, a lot of times you have to take the patient super high on these drugs to get the same effect, right? So a lot of times you're taking them way above the FDA approved dose. So a great example is like Zoloft caps out at 200. If I'm dealing with a patient with obsessive compulsive disorder or like one of these really severe eating disorders, a lot of times I'll have to take them up to 400 milligrams to still get that exact same effect. They're a lot more resistant to treatment. Right? So a lot of times, again, these patients tend to hide it. They don't want people to know that they're vomiting or doing these compulsive mechanisms, right? Russell sign. So Russell sign is if you're looking at somebody's hands, we tend to see it more in somebody who's vomiting. So remember, when you're vomiting, that hand, you're using it to purge, and then it's scraping against the teeth. So over time, they'll have a higher, the skin will get thicker on the two fingers that they're using. So when you're looking at somebody's hands, you'll see a lot more of a like hypertrophy on the hand on those two fingers that they're using because it's constantly getting scraped up by the teeth, right? When you guys are doing your physical exam, this is why it's important to kind of check that dentition, because if somebody is purging and they're vomiting, there's a lot of stomach acid that's in there, and this is something that they're doing pretty routinely, so it's actually slowly eroding the back of the teeth. So this is where sometimes your dentist can come in handy and be super helpful. When you're doing that quick exam with the teeth, they're having a lot of sensitivity on the back ones. That's one of the things you can kind of keep in your differential when you're doing that physical exam, right? They are at risk for suicide. That's pretty standard for a lot of these conditions. A lot of times, this is less of a significant medical concern because they are maintaining that more normal body weight. They are actually still eating. They're not restricting. But if they're purging a lot, it can cause an imbalance in the electrolytes, specifically with, I want to say it's potassium again because they're vomiting. And now all of a sudden they can go into a cardiac arrhythmia because of the bulimia. So you do need to watch it. You need to order that EKG, see how they're doing, right? Good. So that was bulimia. So now we're going to go into binge eating, right? These are all very kind of similar. So remember, with anorexia nervosa, it can be restrictive type or it can be purging type. And then what do they have to have with anorexia? Low body weight, so you need to have that BMI. Then I'm going to go into bulimia nervosa, right? So, yeah.
Sir, I was noticing this purging behavior for anorexia, it doesn't list excessive exercise.
Mhm.
Is that not included in
They can still be. Yeah. But a lot of times they're in more of a caloric state, so having a lot of exercise is a little bit harder for them to do. A lot of times more is they're depending on the laxatives and the vomiting and stuff. But yeah, it's still a purging behavior. They can still have it. Yeah. Okay, so anorexia. So bulimia, remember, bulimia, can they have a normal body weight? Yeah, they can have a normal body weight, but what do they have to have for bulimia? Right? There has to be some sort of compensatory behavior. They have to be doing something about the overeating, right? That's how you can differentiate the two. It's one, the body weight, normal body image, and one has to have the compensatory mechanism, right? So what if somebody is overeating, they're having episodes where they can't control their eating, and then they're vomiting to control it, and their BMI is like 15. What is that? Anorexia, right? Perfect, because now they have that BMI, they're in a caloric state, it's dropping down, right? Because they're meeting that criteria for BMI. Good. So now we're going to go into binge eating. Binge eating is very similar to bulimia, except they don't have that compensatory mechanism. The big one with this one is they're just overeating and they legitimately can't stop eating to the point where they feel uncomfortable. It can actually be painful. A lot of times they're feeling an intense shame about this overeating, so they're trying to hide it. That's how you can kind of separate this one. Right? So again, that recurrent episode with no compensatory mechanism. That's how you separate this one out. They're not doing something about all the food that they ate. Right? Otherwise, the category is still pretty much the same. This one has a 3 for it. So eating too fast, uncomfortably full, large amounts, even when not hungry. Again, they're trying to hide it, and they feel bad about it, right? So you only have to have 3 of the following. But there needs to be some sort of shame associated with the food. They need to be trying to hide it. Again, they're overeating to the point where they can't control control it. Right? Once per week for 3 months. What is your time cut off for that one? Right. And there's your pink box. Kind of goes through the same materials. You guys have that one as well. I won't read that to you because again, it's kind of like that same rundown. Right. Treatment for this one. A lot of times we depend more on the CBT for this, or some sort of other therapy is going to be your mainline treatment for this. SSRIs. It depends. I've had some success with it. I've taken care of quite a few patients that have the binge eating side of it. And it helps with a lot with like the shame, the disgust, the anxiety. That's really what you're targeting with the med. And a lot of times, again, there's that comorbid. They're having a lot of anxiety about it. Maybe they're depressed about their binge eating. And you're trying to fix that condition, which is going to make your therapy a lot more effective. And these patients, because they do have a tendency to be overweight, I do definitely try and avoid the meds that are going to cause a lot of weight gain. And then otherwise, if it's a med that can cause a little bit of anorexia, it's not necessarily a bad thing. You just got to be a little bit careful when you're talking with patients about eating disorders, because what you don't want to have is now you flip them into an anorexia or a bulimia with just your med. Right? So big thing with this one, remember these patients tend to be a little bit overweight, so we want to drop them back down to a normal body weight. So with anorexia, we want to bring them up to a normal body weight. With bulimia, we want to get rid of that compensatory behavior. And with binge eating, we want to drop them back down to normal weight and get rid of that overeating category. And when we're talking about treatments, that's our down and dirty goal for all of the eating disorders. So this one's a little bit more straightforward as far as the categories go. Yes?
Sir, I guess I'm kind of getting confused. So with bulimia nervosa, I guess like once they go down and they lose a lot of weight, does it automatically then become anorexia, or just binge eating sometime version?
Yeah. So if it's to the point now where they're having that caloric restriction, they've lost a lot of body weight and they're below a normal BMI, and they are binging and purging, that's going to turn into an anorexia nervosa, right? It's not super common because a lot of times with the bulimia, they're overeating. So they're still getting enough nutrition, whereas with the anorexia, a lot of times it's more they're restricting what they eat, and then to get rid of the little bit that they do, they're vomiting. So what I'll see is the patient will, because again, family members will catch on that their member is struggling. So what they do is they're trying to get that person to eat. They're badgering them, making them feel bad about the food. So what they'll do is they'll eat a little bit in front of their family, and then they'll go immediately to the room and they'll go and purge it out and get rid of it, right? That way they took something in to make the family be quiet, and then they're going to go get rid of it real quickly, which is still keeping them in that caloric deficit, right? Whereas with the binge eating, with the bulimia, there's overeating in very set episodes, and they tend to try and hide it, and then they're getting rid of it after the fact. Yeah. It's a little bit harder for the family to catch on with that one because their appearance is still pretty normal. Does that answer the question? Cool. Anything else for the eating disorders? Again, a little bit of a shorter one, a little bit quicker, but it's kind of a little bit more dry. Biggest thing I'll tell you all from the primary care side is if you do suspect an eating disorder, 100% get nutrition on board early, get psych on board early. Don't be afraid to place those referrals because these patients, they take a long time to manage over time. And there's a lot more difficult to deal with. And it's not because of them, it's just the condition is such a hard one, so deleterious to their health. All right. Good. So let me pull up the next one. All right, OCD. Does anybody need a bathroom break? We went pretty quick through that one. I don't want to do this. so now we're kind of moving on to obsessive compulsive disorders, with the big one under this category being OCD, right? That's like your classic one that you're thinking about. I was too short to bring up a kind of a picture from this one. Does anybody know, I'm trying to think who has a famous OCD? That you guys would know. Yeah, probably like your best one. Monk? Yeah, Monk's probably a pretty good character to kind of keep in mind. So with OCD, there is a difference between OCD and OCPD, right? When we go through the personality disorders, that's the one that we'll talk about. Anytime somebody is telling you, they're like, oh, I'm OCD, I'm just very fastidious, like, oh, it has to be my way. They're not talking about OCD. OCD is pretty a severe diagnosis. They're probably saying that there's OCPD, which means they're just type A personality, right? There's nothing wrong with that. OCD, the patient is upset about it. They know what's going on, and they legitimately just cannot control the rituals that they have to have in their life. A lot of times with OCD, they're having an obsession, and it's not like a nice obsession. With these patients, that obsession is actually like a lot of times really negative. So I was taking care of a patient, female, she was married, she had 3 kids. Her obsession was that she would legitimately kill her family with a knife from the kitchen drawer, right? And that thought was just constantly permeating through her head. And her compensatory mechanism to deal with that, it was she would clean her house from top to bottom, right? And that's what she would do to get rid of the thoughts, right? These, when you have OCD, these obsessions are not nice. They're not good thoughts. If a lot of times if you're male and you're a straight male, sometimes the thought that's coming into your head is that you're homophobic, you're gay, and no one's going to love you, right? And again, this thought is constantly hitting them in the head, and they have to have a compensatory mechanism to deal with it. Another theme, one that I've seen that's pretty bad, is that the thought will be telling you that you're a pedophile, right? They have this obsession that, oh, people are going to say that I like kids even though I don't, and they're not going to believe me, and everybody's going to be against me. It's not a nice thought to have. And then to get rid of that thought, they now have some sort of ritual, right? Another classic one they're going to think about is germs. So somebody starts to become obsessed with germs. They think they're going to be sick. Their family's going to be sick. Something bad is going to happen. So now they go through their house cleaning it from top to bottom. I had another patient who was concerned that somebody was going to break into his house and attack his family, right? That was his obsession. He was always worried about his family's safety. So what was happening was he was legitimately checking every single lock in his house, not once or twice, but 7 times. So he had to check it exactly 7 times before he could ever leave the house, right? And then if something happened where that process was interrupted, he'd have to start all over again and start rechecking all the locks. So it was like legitimately leading to him being late to work. He was missing formation because of this thought, right? So when you guys think about OCD, yes, the TV shows tend to portray it as like this, oh, they're just super analytical. Like, it's a very negative thought that's occurring with this, and it's distressing to the patient. All right. Syllabus, essentially the diagnosis. So they have to have a preoccupation or ritual that's distressing to the individual. And again, it's going on for a long period of time without normal periods. Okay. Obsession, that's that recurrent thought. So, and then they have to have, so technically they don't have to have a compulsion. They can just have the obsession. But it's very rare. Even when you're talking with somebody, usually there's some sort of compulsion going on in the background. But technically you can make the diagnosis just off of an obsession, right? Again, making sure that it's not substance or medication induced. We always have to do those checks. So, hey, remember I was telling you those stories that obsession is actually causing some sort of effect, usually like really severe anxiety within that patient, where if it's interrupted, they feel really bad or anxious about it, right? That's your obsession. And then compulsion, or repetitive behavior active center response. So that's where they're cleaning their house from top to bottom. They're touching those locks 7 times over. They're washing their hands multiple times to get rid of those germs, right? There has to be some sort of compulsion that's going on with that. And then that compulsion, it's not because they're worried about their hands being sick or they don't think they locked the door. It is the process that they've developed to get rid of that obsession and that anxiety that's associated with it. It's what they found that works. They're basically treating themselves by doing this ritual. Right? There's your pink box, right? Good. Okay. Severity level, I'm not going to really expect you guys to know the specifiers for this, but there are some specifiers, so you can understand what's going on or you cannot understand what's going on. That's what we're talking about with good insight versus poor insight. Tick related, this is where you actually have some sort of physical body movement that's associated with that. I was taking care of a patient, and I think I've told you guys this one. So she essentially had a tick where she was constantly, one, rubbing the bridge of her nose, and then she was rubbing a part of her hand to the point where she legitimately had abrasions. It was breaking the skin barrier. We were actually having to start a little bit of bleeding going on because she was doing it so frequently. And she also had a tick where she kept looking to the corner of the room, like over and over again, while she was talking. So she'd be talking with a full sentence and go, and take to the left side of the room, right? To the point where I'm like, hey, is there something you're seeing over there that I'm not seeing, or why are you looking over that way? It's kind of a very odd behavior. Yeah, so I think somebody had said Howie Mandel, so you guys can definitely watch that video if you want to. I'm not going to make you watch that video right now. Right. Treatment-wise for OCD, we definitely want to get therapy on board. And then medications, we actually want meds on board as well. Just realize, like I was talking about with your treatment windows, OCD is a lot more difficult to treat. Our windows go through the roof, so now you're looking at like 12 weeks before you really see a response. And my doses tend to be a lot higher in order to get the exact same response, because it's a difficult diagnosis to treat, right? Clobazam, TCA, it does have an FDA indication for OCD, but in general, I actually tend to prefer my SSRIs because they are safer. So in this scenario, what's a great med to use? What's that? Fluvoxamine, right? Because it's the only indication it has is OCD, right? So in this scenario, hey, it has an indication for it. It can be a good option to use in these patients, right? In reality, any of my SSRIs, they tend to work pretty well, but fluvoxamine actually has that one indication for it, and what's kind of makes it unique. Right? For differential diagnosis, when you're talking about OCD, because it can present as a couple different things, so your anxiety disorder, maybe this is kind of more in line with like a generalized anxiety disorder. Body dysmorphia, I think we'll talk about body dysmorphia here in a second. That's kind of this obsession with your image. A lot of times it can be male or female, it can be musculature in males, or it can be body size in females. It's different from anorexia or bulimia, which we'll talk about. And actually, I would argue we're seeing an increased rise in body dysmorphia within the population because of social media now, where everybody's able to view everyone else. Everybody has kind of these unrealistic ideas. Everybody's posting videos about themselves at the gym, working out. You're like, I don't need to know that. But we're kind of starting to get this rise in there. Okay. And again, suicide is actually a problem in the OCD population because these rituals can be, one, the obsession is so distressing to the patient, and then two, the ritual takes so much time that we tend to see a higher risk of suicide in these patients. So there's definitely something to be worried about in this population when you're talking with them. Okay. Right. The next one, we go to bodily dysmorphia. It kind of takes, there's one specifier for it that tends to be very unique to the male population, and that's muscle, whereas the female, it tends to be more just on their image compared to those that are around them, right? I have taken care of a couple patients with this. So this is your person. So if you wanted to think about a generalization and a caricature, right? This is that person that's at the gym in front of the mirror, and they're like flexing for like hours and hours and hours, and you're like, dude, what are you doing? We're here to work out. Why are you spending hours? Why are you videotaping yourself? That is kind of like your classic picture of somebody who has body dysmorphia, right? They're very obsessed with their appearance, how they're looking, and what they're doing, right? And they're taking a lot of videos, pictures, things about that, okay? In females, we tend to get... Yes, but no. So that's your male population. And females tends to be a little bit more focused on the hair, on their skin, on their nose. So your patient, so if you're working in like surgery and you're working in plastics, right? This is why psychiatrists, we tend to hate plastics a little bit. Is because those patients, they're very obsessed with their physical features. So a lot of times you're thinking about nose jobs and stuff like that. That starts to fall in the category of body dysmorphia. That person who's had like 5 different nose jobs and now all of a sudden they're looking super artificial, that tends to fall in the realm of body dysmorphia. They're going to change something about themselves and they're never happy, so they're going over and over and over again to make those changes, right? Those people that are looking like very plastic Barbie doll-like and they have like the really crazy duck lips, the Botox that's holding them back, and like the boob lift and the lipo, like there's something to be said like, yes, we can definitely help them with having all anxiety with how they look, but also you have to be careful when you're talking with those patients. Because now it's not necessarily just, hey, they had a baby and they're trying to get back to what they were. It's truly body dysmorphia, and that surgery is not going to do anything. It's going to reinforce what's going on, and now you put somebody through the surgery for no reason, right? All right, I'll get off my soapbox. Okay, I'm done with that. Sorry. So again, preoccupation with a perceived deficit in physical appearance. So this is not just an obsession with weight, which is kind of where our eating disorder is coming from. This is an actual some sort of feature on the person themselves, all right? And again, it has to have some sort of effect on your life. So again, those influencers, if it's not having an effect on their life, then it doesn't meet that category yet, right? It has to have that disorder effect. Good. Body dysmorphia, so that's your pink box for it. Mirror flat dressing, excessive grooming, skin picking, reassurance seeking. This is where you see people taking like 100 photos of themselves and they're showing other people photos. That's a lot of what I see now with new technology. Yep.
Sorry, you said it has to have an effect on their life.
Yeah.
If they are cognizant of and find a way to live their life where this is actually a beneficial thing, how do you differentiate it? Because an influencer who has body dysmorphia and works out all the time is like, guess what? I can make a bunch of money by making
Yep. So a lot of times, so what I'll see, especially with like the working out and stuff like that, is they're exercising so much that they've actually injured themselves, right? So that they've torn their ACL, their MCL, they've thrown out their back because they're not giving their body proper time to heal, and now that's having an effect on their life because they're injuring now. So that's how I'll see that link back in. But if it's not having effect, so like they're happily married, they're not spending a ton of money on surgeries, they're still at their job. Another case I had, like the marriage was literally falling apart because the patient was waking up at like 5 in the morning to go to the gym, and he would be there from start to work day. And then when work ended at like 5, he would go to the gym for like another 3 or 4 hours. So essentially from like 5 to 8 at night, and then he would go home and he'd go straight to bed, right? Well, he also was married and had a kid. So essentially he was spending no time with his wife and kid because he was so obsessed with his appearance, right? So now we're having an effect that's in there, right? So does that clear it up or muddy it more?
So it's a different effect.
Yeah, different. Yeah, that's where you have to talk with them and figure out what's going on. It's never going to be clear cut where they come in and they go, I lost my job because I was at surgery too often. They think it's fine for them, but you have to like figure out like, hey man, like, you noticed your wife is super upset with you. Yeah, that's why I'm here. She's just the worst. And you're like, okay, well, why is she always upset with you? Well, because I'm working out. I want to look good for her. You're like, okay, well, how much time are you spending at the gym? Oh, like 4 hours in the morning, 4 hours at night. And you're like, do you see the problem? Do you see the connection? And a lot of times they don't. So, if it's obsession with muscles, that's where you need to add in the specify with muscle dysmorphia. If it's not an obsession with muscles and it's more obsession with like a facial feature, hair color, something like that, then it's actually going to be just body dysmorphia, right? So you can't add that specifier that's in there. Okay? Good. Any questions about body dysmorphia at all? Treatment-wise for this, meds aren't really going to do anything unless they're having a lot of anxiety or something like that. Then I'll throw on the med. But really, it's going to be therapy. That's who you want them to go to. The therapist is going to help with their cognitive distortions. Usually, it's going to be CBT. There's no other like set therapy that's been proven that's specially designed for this. But you want to get them in with a therapist more because my med is not going to make them stop wanting surgery. My med is not going to make them stop going to the gym. Okay. Any questions about body dysmorphia? Yep.
Joking aside, sir. So, with Vic Delineator and actually social or other physical sequelae at that
Mhm.
point. It's not a 24-year-old who is sauced up with needles, muscle seeing
Mhm.
right? It could be that if there is a physical sequela or a emotional relational sequela.
Yep.
But it's more your Yoshino before it's 95, and like before it's 95, he's locked in.
Yeah. So remember, for something to be a disorder, it always has to have some sort of impact on the person's life, whether that be social, whether that be occupational, whether that be within their peer group. But for something to be a disorder, it has to have that effect. It's taking some sort of aspect on their life, right? Another good example you could argue is I'll go back to my male population. If people are going to the gym and they're still unhappy with how their muscles look within the bodybuilder community, especially with online, they were injecting Synthol, right? Which again, like, it's not actually making you stronger, it's not making you bigger, but it puffs you up, makes you look bigger, and there's a lot of side effects to that. You could argue, now that you're having that effect on their life, that now that's reaching body dysmorphia, right? Because they're doing something abnormal because they're obsessed with their muscles and how their appearance is, right? Does that kind of make sense? Yep. And then like your female population, again, the classic example is, if you're thinking, so I'll give you guys a good example because he's dead. Michael Jackson, right? Michael Jackson, like, started off for the fun, then he kind of went off the rails, and he had all those nose surgeries to the point where, like, his nose fell off and stuff like that. You could argue that that was body dysmorphia because he was having multiple surgeries to change an appearance about himself because he was obsessed with that, right? Now you can kind of see where that starts to play out. Good. Yep.
So can I generalize it as like all those influencers are kind of having this type of disorder?
So you don't want to just start adding diagnoses to people because, again, if that's how they're making their living, that is their occupation, then it's not necessarily having an effect on their life, right? Because that's legitimately the profession that they've chosen. So they have to have that appearance as part of their occupation and their job, in which case that's not a disorder, okay? But if you're posting all these videos about yourself as kind of an obsession because you need that fulfillment from other people, you need that constant reassurance, and if you don't get it, it's bad. Now it's dipped into the realm of a disorder. Right, so don't forget, with social media, it's kind of changing a lot of the stuff, and the DSM-5-TR hasn't caught up yet because we don't truly know. So sometimes it's just their job, and that's how they're making money to support themselves. Yep.
So for people that are diagnosed with this type of disorder, do they get like agitated very easily by slight comments?
Not so much as that they just need that constant reassurance from other people sometimes, more than need that reassurance from themselves. And if they're not getting that, they're kind of concerned like, oh, well, I'm not getting this because of my appearance, because of this, or because of that, right? Good. Any other questions about this one? Cool. All right. Therapy, SSRIs, good. Again, this is where I say, like, you want to be cautious putting these referrals to derm and to plastics, right? Because one plastic surgery might say no. Eventually, you're going to find one that says yes, because that's how they make their money. And then a lot of times, what that'll do is it'll reinforce what's going on with that patient. Okay, I'll put up myself once again. Sorry. All right. Hoarding disorder. Yeah.
Sorry, actually, sorry to emotionally jerk everyone back to this, but back to the front, it was saying
To the front.
preoccupation, earlier on, is preoccupation with a flaw that is not observable by others. So, is there a case, or is this going to be something that you'd be concerned about with, say, like a burn victim or something like that, with like severe cosmesis, like to their face or something like that? Is there a delineator there? I mean, because obviously that's reasonable.
Yeah, so in that scenario, I would say they probably don't have body dysmorphia because they legitimately have anxiety, but it's about a known condition, right? So in those scenarios, I would actually use a different specifier, and I'd actually say it's probably anxiety due to a medical illness. I'd actually use one of my other specifiers for that, right? Good question. Good. So yeah, it's not to say they don't have a disorder, they probably do, but there's a better diagnostic code for it. Cool. All right, good. Now moving on to hoarding. So hoarding is also a compulsion. And believe it or not, it can actually be one of our specifiers for one of the personality disorders that falls into OCPD. But this is those people that they just can't let anything go. They have to hold on to everything. And if they release something, it causes a lot of anxiety for them. Because they have that perceived value associated with it. This is also why it makes such a great TV show. Because these patients just hoard like stuff that doesn't necessarily make sense. Talking like newspapers, old videos, magazines. They're just holding on to the stuff. They can't ever let it go because they might. This is not my wood pile in my garage. That is all reasonable. I need those pieces of wood. Alright, it's completely different. Alright, what's that? Exactly. They're for a future project. It's different. Right? So again, it's having a hard time letting go, and they're holding on to stuff like their old computer from the 90s that isn't even reusable anymore, right? They just had that, right? They need to save the items, and they have a lot of distress if they get rid of them. They just keep collecting over and over and over again. And then they have, again, you have to have that clinically significant that distress, not explaining with something better. It's pretty standard for everything. There's your pink box that's associated with that, right? As that same criteria, but a little bit laid out for y'all, a little bit more descriptive. You guys can read through that. I can't remember that one off the top of my head. Anyways, cool. So hoarding, again, that biggest thing is if we're painting your scenario for this is that person that just has a bunch of stuff, they can't ever throw it away. It's a pretty straightforward diagnosis to make. It's just the treatment for this sucks. Because again, no med is going to fix this. They need therapy. And it's hard. You have to if you get rid of all their stuff all at once, they're going to have a horrible effect, panic attack, anxiety. It's hard, right? So you have to slowly get them to let go one piece at a time. So it takes time. Or eventually they die, and then you have to go in and clean up the house. You just bring in a huge dumpster and just chuck everything away, right? This is how it goes sometimes. Right? So anytime you're messing around with the brain, so like TBIs, concussions, that's why we care about them so much on the psych field, is because if I'm shaking that brain around and it's a hard drive, it never goes back perfectly to the way it was, right? That's why concussions are so cumulative. We don't like patients to get multiples of them. So every time I shake the brain, it just doesn't go back perfectly the way it was. That's why the NFL is taking such a huge interest in it. And you're seeing that it's not an official diagnosis yet, but CTE, which is essentially just this accumulation of micro TBIs that you're getting over time. And from the military side of it, it's something that we're starting to investigate a lot more with our overblast injuries. Because now all of a sudden you're getting exposed to an overblast over and over again because you're artillery. Like, well, what effect does that have after you've been doing it for 20 or 30 years? We don't necessarily have good data on that yet, but it's something that we're looking into. Right? So again, very difficult to treat. We want them in with CBT. CBT, you guys are going to be so tired of me saying CBT, and it's a little bit of a lie, but for y'all's level, like CBT, you see that on a test, 9 times out of 10, it's going to be right. And SSRIs, again, it's more kind of treating, it's an augment to the therapy, it's helping control that anxiety, it's not doing anything for the condition itself, right? Good. Yep. These are your people that are always going like to the garage sale and you don't know why somebody's buying all your stuff for like 25 cents, probably because they're a hoarder, right? Sorry, it's a generalization. All right, good. Any questions about hoarding at all? So it's still a compulsion, it's still an obsession, but it's actually more focused on just keeping a whole bunch of stuff that has no value, and if you get rid of it, you get upset, right? Good? Okay. Trichotillomania. So this is that hair pulling, right? So actually you'll see this quite a bit, and this can actually be one of your causes for hair loss, and also one of your causes for alopecia, right? Is that person is legitimately, when they're stressed out, they just pull their hair over and over again, right? I see some of you guys doing it during the tests. Or you take your hair and like they're the ones that are constantly twirling with it and messing with it, and then it just pulls it out, and then it gets bad enough where you actually have a bald patch start to form, where you get thinning in the hairline because they're using it as a mechanism to deal with their stress and their anxiety, right? So next time you guys are taking your test, get bored, look around the room, you'll see the people in the corner like freaking out, right? It's okay. I've done the same thing. Right? So repeatedly pulling one's hair out and they can't stop. So again, it's now become a point where it's deleterious because they can't stop themselves from doing it. Most commonly, we're seeing it on the scalp and the eyebrows, but anywhere that there's hair, you can have this effect. That's where we're most likely going to see it. Right? A lot of times where we see this is that social impairment and occupational because they're becoming upset because they're having this loss of hair. And they're kind of becoming concerned about it. And you'll see people wearing wigs to cover up for it. You'll see people doing the hair extensions and stuff like that. Or they're kind of like shaving to hide it and stuff. There's different mechanisms that they're doing to deal with that. What's really bad is when they actually eat it. Because then what can happen is now it's become a bezoar and it'll actually sit in the stomach and it actually forms like this little stone that has to be removed through surgery. Usually you see that in like kids because again it kind of turns into this almost control mechanism. But you can't, that's why you always kind of want to ask, maybe throw on an abdominal exam just because there is that risk they could be eating the hair as a way to hide it or to control their anxiety as part of the ritual. And it can cause some other problems with the digestion system. Right? Other OCD, psychotic, again, it can be part of the ritual, psychotic disorder, or just normal hair manipulation. Some of us just mess with our hair when we're bored, right? Good. Believe it or not, meds, these are just to fix the hair loss. They're not anything that's psych related. Hydroxyzine for the anxiety, we do use it quite a bit for that. That's your Atarax. So it's very situational anxiety. I like to use hydroxyzine, but it's actually just an antihistamine. Antidepressants can actually be pretty useful for this because if the anxiety is the primary cause, we can get that anxiety under control. All of a sudden, the person's not having that compensatory mechanism to pull their hair out. So a lot of times with meds, I'll be pretty quick to throw meds on with this one. Again, SSRIs are going to be your mainstay of treatment. If they have other stuff going on, I may look at my other ones with SSRIs. Antipsychotics only if it's like really severe. That would have to be a pretty significant case before I jump into the antipsychotics. And again, any rough answer when you're dealing with antipsychotic, you always start with the second generation. If those fail, you go to a first generation. That's rough answer. All right, excoriations. So this is where you have that constant picking at the skin and stuff like that. You just kind of do it over and over and over again. A lot of times what I'll see with this one, it could be it's commonly with the nails or the fingers, and they're just picking at those pieces of skin and they're pulling them off, right? And maybe they're in a meeting and they're just bored or they're getting anxious because they're about to present and they're just constantly pulling at that finger skin, right? To the point where now they have bleeding and stuff like that coming from the fingers. You can also see it at the lips. For a while there, my kid was doing this because he has a little bit of kind of social anxiety in the school setting. So he'd be sitting there on the way to school and he'd be pulling the skin at his lip, especially when they got dry and your skin types was like, he'd be pulling at it. So we had to like, hey, what are you doing? Like, calm down. We had to point it out to him. That's another place that you'll see that as well. When you're dealing with excoriations and anything to do with the hands, if you're doing a physical exam, always do those quick checks to make sure that it's not something else, specifically like scabies or lice or something, because then that infection will get passed off to you, especially if you're dealing with like the homeless population. All right. Again, they're trying to stop it and they can't stop it, and then they're distressed about it. That's what you're talking about with an excoriation. And then these, you'll actually see the lesion. So this is one of those ones where that good physical exam will help rule in this diagnosis, because you'll actually see, again, remember that abrasion on the nose, you'll see the skin picking from the fingers, the things on the lips, you'll actually see that. And a lot of times they'll actually do it in the room as they're talking to you, because they just are unaware of it. At that point, they're getting anxious talking with someone, and they'll start to do it, so you can pick up on it in the room. Good. There's your pink box for that one. Nothing too crazy with that. There's no time frames associated with this one. You'll just find it on exam and you can make that diagnosis. Good. Differential diagnosis for that one. Meth, cocaine, hell of a drug. Makes you do some crazy stuff. My first hour in the ER down at the Methodist pod, not Methodist, this was at UT Health in downtown San Antonio. The doc's going through the list, and one of the patients is like, yeah, this guy's on meth, and he sexually assaulted his cat. And she's like, wait, hold on a second. Meth, it makes you do some crazy stuff. Again, it's harder to treat. CBT and SSRIs, again, are going to be your mainstay of treatment for that one. I don't necessarily think it's super difficult. If you can get at what's actually causing the anxiety and you can address that with your patient, you'll have a lot of success. It's just you have to work with them and figure out what actually is the reason that they're doing that. There's usually going to be some sort of underlying reason. All right, that's our obsessive and compulsive disorders. Any questions about that at all? Nope. Okay. Take your 10-minute break. Let me see if the substance use one is a pretty good slide deck, and we'll see if we can knock that out. We'll see. I don't know how long it is yet. Yeah, you guys have nothing to tell about voices, right?
I don't know, I had two of them. I hope he doesn't do this one. This is long.
This is nice in here.
I'm gonna say if we're gonna do another one, I'm gonna do right now. I will just as we're social media. Yeah, I'm gonna
It's 100 slides. Or 90. Yeah, I'd rather go read. Yeah, this looks whack. It's so like objective. All of this is not straightforward.
It's like reading it like a few times. I need to read all of it again this weekend.
Because you never know. What somebody's telling you the truth.
Yeah.
I let her know. The 21st.
What?
Yeah, probably. It's right before the test.
Is the eye? Oh my god.
That's what I'm telling you. This is like an every other day.
My wife will bring me green beans and casserole.
Today I was like,
I'll make it.
Way.
I guarantee mine.
Is that?
Oh, yes, sorry.
that was something that was like,
I make the pecan pie that
I opened the portal to use
All night stress.
Yeah, you know the this hemisphere is largest for confarms is in New Mexico, right? Yeah, you know that. Do you know that?
Can you see?
Where are you from? You live in the same
Does it
state?
hurt? No. Okay.
The northern hemisphere is largest for confarms. Do you?
I do not. I do not.
I was in bed by like right after I texted you guys. I pretty much fell asleep.
I figured.
I'm rejuvenated.
The texts are getting slower.
The bloodline? You mean she doesn't currently?
I could make that argument. Someone already made a spreadsheet. Someone already made a spreadsheet. Speaking of spreadsheets, I was gonna make.
Air Force, you guys love your spreadsheets. I like to pick out a few colors for my spreadsheets. It's usually all of the spreadsheets that I
We also remember this class also originally was also on Monday or Tuesday afternoon, and that class was moved. It was the fact that Clean Lab was canceled and they couldn't move up the lab. So it was more the lab that's holding up that. He helped with that because his class was really originally more than me.
I think we should just show up.
That class changed. And as long as you know you can see the labs and you just that long past those outloads yeah, you can do the pickaxe or something like in your head as well. So as long as you can do that. Last week, where our schedule is now during 12 o'clock is starting next week. We only have one of the programs, I don't know if it goes out. One or three program days, so like that. I think these have to be long enough. Another one for
What did you get?
the 15 days. So,
Can you add stuff to it? Do you want to make it bigger? Make it easy to find? Okay. Just rearrange it so it's the side of the substance. One side of it.
like in the class, like
Yeah. Yeah.
Well, you guys have fun with that. I'll do my best. Fucking one like.
We also have my slide.
Yeah. When you go over the slide, like all you would do is like questions rather than like actually go through the
There's a lot of stuff.
Yeah.
We have a
Look at the value. What value should you use? If you're talking to you and if you're going over if you're going over GDP, that's all stuff. So you look at the value and now it's like, okay, this is now you go into like what's the you make this are we talking about the product and the delivery. Yes, and then with the waxy cast, you have to go fast. Yeah, fast. So just think about it like that to figure out, okay, what order we're talking about. And then talk about entry, right page,
Upset the compulsive. That's my sister.
What's next?
Because your ambulance is so like you have to take your time to ambulance, like daily life is, figure out fast. It's a kind of ladder down quicker versus the light. Is specifically that like another part of the release has a 9,000 times of license than any organ. Oh, yeah, that's like the best indicator for like cardiovascular. No, we're done. I don't know, honestly. I think he's trying to figure it out.
You know what I mean?
Roast.
Really nice.
Oh,
She said the worst guy. I don't think it's you.
Why would you think that?
Yeah.
So this is what I was that's why I'm sorry. I don't think it.
And they basically switched now.
Yeah,
because the pattern was saying that.
Because these guys make sense. Because if the issue in the liver, yeah, that makes sense. At least we have some content. Oh, yeah. What we're saying is that like pathology is one thing in the lab or the job that's why like she's saying she's saying that's pretty like the pathology. But then again, it's quick by. I will say, yeah, but like, I can't say, oh, pathology is like, that's I said definitely. It should 100%, but that's not why. So what through it?
I'll go through.
Who's we that was brought? I was like, I don't, like, I knew I saw it.
Yeah, don't worry.
My wife's here.
It's like sentimental, right? It's industrial. It is. I know it's funny too because she was.
I don't think it's very John.
It's interesting. I've been doing these.
Or something like what's talking about it, but like that's not lab. That's not lab job. Lab is not what it's supposed to be. Their job is to be the lab. That's on you. So we're going to learn about. So like, say.
That's not just like.
Alright. So we'll go ahead and we'll get started on this one because I guess group consensus was that let's do another one. So we will do that. Okay. If you didn't want to do this, then you should have spoken up and been louder, right? Group consensus. Okay. So we're gonna go. I want to do some updates to the neurodevelopmental one. I want a good chance to sit down and actually go through that, just because autism spectrum sort of can be a little bit confusing and stuff like that. So we're gonna use the substance abuse one because this is the last one in the deck. It's a pretty good one. I don't need to make any major changes to it. So as is, it's still good. So anytime you're dealing with substances, what I'll tell you is the diagnostic criteria to make a use disorder is pretty much exactly the same, regardless of the substance, right? You always have to crave it. You always have to have a preoccupation with it. You're always doing dangerous behaviors to obtain the substance, right? And then it has to have an effect on your life, right? Or then you're having withdrawal symptoms, you're building up a tolerance. That's pretty much the same throughout all of the use disorders. You're just supplementing whatever the drug happens to be. Whether it's alcohol, whether it's methamphetamines, whether it's a stimulant. What makes them kind of unique is usually going to be the intoxicated state. So the prodrome, the intoxicated state is going to be different for every single drug, and then the withdrawal is going to be kind of different for every single drug. There's certain things that kind of carry over, like a lot of agitation and anger. That's pretty consistent for a lot of them, but those are going to be the unique. So you have to kind of learn that aspect to it. Rough, down and dirty is when you're talking about withdrawal states, whatever the drug does, the withdrawal state is usually the opposite, right? It's not perfect, but that's kind of like a rough way to think about it. So opioids, they tend to sedate you, make you super tired, make you cognitively unaware. When you go into withdrawal state, you tend to get super sweaty, super agitated, it can make you have diarrhea. So it's kind of like the opposite of it, because opioids will stop you up, right? So it's kind of a good way to think about it. Good. So tolerance, if you always need more of something to get the exact same effect, that's called tolerance. Intoxication, that's when your mental or physical abilities are changed. That equals an intoxicated state, pretty straightforward. Physical dependence, that's where you need that substance to stave off bad reaction. So classic one being opioids. You always need more and more of that opioid, otherwise the moment it stops, you start to get really nasty cold and flu-like symptoms, right? Addiction, so something starts to reach that addiction category when you have a strong, you're always craving it, you always want it, and that becomes the central theme of your life. Right now it's become an addiction. And of course, withdrawal, when you stop the bed, bad stuff happens. Good. Yeah, so lifelong is probably like the biggest takeaway from this slide. And that's just more to see you as a clinician. Just recognize when somebody has a use disorder, that's something that they're going to be dealing with throughout their entire life, right? That's why we have AA groups, and somebody will always say, like, I have 20 years sober. It's just a matter of time, something bad will happen, and then they'll have another break. They're going to be dealing with that disorder through the rest of their life. A good example would be Matthew Perry, the guy from Friends. He had horrible substance use disorders. He went through multiple different drugs. He'd been in and out of rehab multiple times to the point where finally it actually killed him because he overdosed on ketamine and I think he drowned in his pool, right? So something patients deal with. So don't ever get upset and mad with them when they relapse. It's just a matter of time. They're going to have that expectation going in. Have that empathy when you're talking with these people. Good. Mild, moderate, severe. Every one of these disorders has those specifiers in there for mild, moderate, severe, in remission, not in remission. That's for all of the use disorders. Essentially, the more symptoms that you have, the higher category that we put you in. Once you stop using, if it's been a while, then we can put you in early remission and then sustained remission. That's the best way to think about these modifiers then. So first one up is alcohol. Again, I just talked literally about this yesterday, so if you've already were in that lecture, great, cool, you get a abridged version of it today. We'll go as much or in depth with that one. Again, that's your criteria 1 through 12 or 11, and these are all pretty much the same. You'll see these multiple times for a lot of our disorders, right? It always starts off pretty minor, where you just kind of are a little preoccupied with it, spending a little time with it, and then it always ends with, and now becomes your life, you have tolerance, and then you have withdrawal symptoms, usually a bad thing, okay? Good. So this is your criteria for alcohol use disorder. That's from the pink box. All right. Hold on, my voice is hurting. All right, so we always want these patients to be in therapy, and this is why Alcoholics Anonymous actually works, right? It's a 12-step program. This was before, when we were dealing with alcohol, that was all that we had. We were talking about the 1900s, right? 12 steps was actually started by a religious figure. I think he was a pastor or a reverend at the time in the United States. And that's why with 12 steps, there's always a religious theme behind it, just because of the guy who started it, right? And so sometimes if you're dealing with a patient who's a very big atheist or they're very resistant to religion, 12 steps might not be the best option, but there's plenty of other ones out there. And they actually have 12 steps now. It's so universal that they have 12 steps for Muslims. They have 12 steps for Christians. They have 12 steps for pagans, believe it or not. So if somebody's telling you, oh, I'm not Catholic, I can't follow along with that, be like, hey, don't worry. We can find a group that's for you. Biggest thing I'll tell you when you're dealing with alcohol is you want that person to be part of a network or a group of other people that are struggling. It shows them, one, that they're not alone, they're not isolated. It shows them that other people have been dealing with this and they have succeeded, and it gives them that support network and somebody to hold them accountable. That's the reason 12 Steps works, is because it's creating a community of people, right? Next, medications. Our medications are highly effective for alcohol use disorder. They work really, really well. Patients are sometimes resistant to it. They say, oh, I can just fix it on my own, or I'll deal with it on my own. Not necessarily the case with alcohol. Alcohol is a pretty bad one. I would highly recommend you get them on a drug, right? Naltrexone is a really good option for you. That's the same drug that we use for opioids. Big thing I'll say with naltrexone is don't get it confused with naloxone, right? They do the exact same thing, but they have different half-lives, different times. Naloxone has a lot shorter half-life. It's only good for a few hours, where naltrexone, we use it as a once daily dosing. It covers them for that entire day. Naloxone is used in that acute ER setting for the overdose. Naltrexone is used in the outpatient setting on just a day-to-day use, okay? If you have a patient that's on opioids for pain control, this is not a good option for them. So if they're an alcoholic and they got into a car wreck and they're getting help for like orthopedic injuries and they need that opioid for pain control, not a good option because it's going to block those opioid receptors and now they're going to be in pretty severe pain. So always kind of get a good history on your patient, know what else is going on with them, right? This also comes in an IM formulation, so you can come in and do once a month dosing with it. That way, you kind of in compliance goes through the roof on that. Disulfiram was like one of the first ones that came on the market, and it kind of works on that negative reinforcement principle. So essentially, we give you disulfiram, you drink alcohol, you get sick, therefore you won't drink alcohol, right? And what they found was that that's not super effective. Negative reinforcement doesn't really work for a lot of people. And anything that contains alcohol has that potential to set off a reaction, right? So you're thinking like hand sanitizers if it's alcohol based. You're thinking mouthwash if there's alcohol in it. Any of that stuff has the potential to set off a reaction. So you have to be careful with those patients. Nice thing to know about disulfiram, again, it doesn't do anything for the cravings themselves. So they're still going to want alcohol. It just punishes them if they touch it. There's also a little bit of a tail with disulfiram. So if somebody is put on it and then they stop it, they can still have a reaction up to 14 days after they stop the med. Not so with naltrexone, right? There's other ones that are on here as well. So acamprosate is another good option. Acamprosate is great if a person has liver disease. And then another good option is going to be when you start going into the off-label world, gabapentin and propionate are actually have an indication for alcohol use disorder. Good. When you're talking about alcohol, alcohol will be bad, right? You're more than likely going to start drinking alcohol in your teenage years, and if you're going to develop a disorder, it's going to show up within that 18 to 24-year-old range. Usually after the age of 40, you're not really meeting that criteria. It's a lot less common for someone to enter into alcohol use disorder after the age of 40. Obviously, it's going to be higher in our males than our females, just because males have a higher likelihood of taking risk-taking behavior. They tend to be a little bit more dumb than the female population. It's just the way that it is. You guys can write about that in the comments. And actually, so genetic component. I don't ever want you guys to think that genetic component, just because you have the genes for it, guarantees that you're going to have it. But we definitely see alcoholism runs in families. Like substance abuse runs in families. That's why it's good to get that good family history. It doesn't ever guarantee you're going to become an alcoholic, but it puts you at a higher risk. You're talking about a 3 to 4 to 5 times higher risk than the general population. That's where you need to counsel your patient and be like, hey man, like you're using alcohol to kind of cope with this scenario. It's not bad now, but like given your family history and the trajectory that you're on, this could become a problem down the road. And it's a tool you can use to do patient education. Good. Alcohol intoxication. So for those of you all who want to be ER providers, you're going to deal a ton with alcohol intoxication, right? People get drunk all the time, they make bad decisions, they end up in the ER. Again, I think we've all seen a drunk person, or I know none of you all would be drunk yourselves, like that would be inappropriate. But we've all seen a drunk person, right? So that third speech, they're not really making a sense, they're uncoordinated. That's why when you're having them do all those movements, they can't really do them anymore. The cops, essentially, when they're doing the sobriety check, that's basically a pared down neuro exam, cranial nerves 2 through 12, right? So you guys, if you're ever worried about something, or you're worried about like a drunk on duty, cranial nerves 2 through 12, they won't be able to do them very well, okay? Nystagmus, so when you're doing those H maneuvers, for somebody who has intoxication, their eyes will legitimately start ticking, you actually see it. So next time you're at a party, and obviously you guys will be sober, but your friends are drinking, you can mess with them and do that, and you actually see their eyes tick, and you can do cranial nerves on your party, okay? Impairment or memory attention. So again, a lot of times this can cause almost like an amnesia or that blackout state where they just don't remember what happened. That's because of the alcohol. It's hitting that central nervous system, and your body can only absorb so much because it has zero order kinetics. There is no half-life to alcohol. So the more you drink, it just builds and builds and builds in the system to the point where it just shuts down, right? Because your body's like, okay, you've had enough. Like, I need to process the 12 glasses that you had already. And that's why stupor and coma, anytime you get an unresponsive person that comes into the ER and you just don't know what to do with them, you're usually hitting them with naltrexone, you're giving them a blood glucose, and you're usually giving them a banana bag because it's probably either diabetes, an overdose, or it's an alcohol and they're going through withdrawal or something along those lines, right? Okay. Good. There's your pink box for that. Okay. Amnesia, that's your blackout. Suicide is a huge issue with alcohol, right? If you guys remember back to that sad persons with guns, one of them is alcohol intoxication. Somebody who is intoxicated, they're at a 7-fold increase for committing suicide, right? It is a significant issue. A lot of times in the ER, we call it being drunkicidal because they will come into the ER, they are ready to kill themselves, they were grabbing the gun and somebody stopped them, but the moment they sober up, they're no longer suicidal, right? So alcohol is a big problem when you're talking about suicide. We see a lot more completions in the drunk people than we do in sober people. Good. Alcohol withdrawal. So remember, there's really only a few substances that are actually going to kill you during withdrawal, one of them being alcohol, barbiturates, and benzos, right? Anytime you're messing with those, you always want to have a higher level of concern and be ready to send that up to the ER, call the internal med team, get something on board, because they can go into those seizures and DTs pretty consistently with the alcohol, right? And again, it's going to be the opposite of what you see with alcohol. Alcohol causes, when you're intoxicated, stupor, slow motions, different things like that a lot of times. So now you're kind of seeing the opposite. It's going to be hyperactive. That sweating is a big one. They start to get a little bit tachycardic because they're going through withdrawals. The body wants that alcohol. Right? You're increasing that hand tremor. If it gets bad enough, it's delirium tremor, so you get a really bad tremor that's going on. Insomnia. So now they can't sleep because they're just not, because they want that alcohol, they're having an activation moment, right? They can actually, if it's bad enough, you can have these auditory and visual hallucinations. And this is where it gets a little bit interesting when you're talking about psychosis. So, your average psychosis, which is going to be like schizophrenia, brief psychotic disorder, it's usually an auditory tone or it's hearing related, right? You're usually not having visual disturbances when you're talking about schizophrenia. If you're having visual disturbances, that's how we can kind of differentiate the two. If you're having visual disturbances in your psychotic state, that tends to be more induced by a substance or it's more induced by a dementia, right? We don't usually see visual when we're talking about our psychotic states or schizophrenia, okay? Psychomotor agitation, again, somebody who's withdrawing, they should be kind of angry, irritable, mad. That's pretty consistent for a lot of our substances. And this is where it gets bad, those tonic-clonic seizures, right? So, has anybody ever heard of CWA protocol or COWS and stuff like that? We're actually using that benzo to cover because of the neuron that's there. You're getting essentially the alcohol has been displacing it, so your body's been building more and more of it to compensate. Now the alcohol is gone. There's way too much of the available for the neurons, and it floods the system, and now you go into a seizure state. So we use those benzos to cover and slowly bring you down safely. So when you're talking about benzos, do you want a short-acting or do you want a long-acting? What do y'all think? Who says short? Okay. Who says long? Good. All 5 of you who voted, thank you. So you actually want a long-acting benzo because you want to cover them for that entire time. If you give them a short-acting, it's going to hit more along the lines of basically you're just intoxicating them again, right? And then they're having that quick drop. That's where we're actually going to be using our diazepam, our lithium chlorodiazepoxide, are going to be your 2. We don't want to use Versed, we don't want to use midazolam, we don't want to use Xanax because it's too short-acting, right? And essentially we just step them off over time. And there's a whole protocol for that. I won't go through it in this because usually that's going to be your ER, that's going to be your med surg team that's going to do the acute withdrawal management. Psych will get them after that once they've kind of like stabilized, right? So I'll leave that talk for them. But just be aware there's a protocol to follow, right? That's why, interestingly enough, if you have to take somebody down through withdrawals, because, I don't know, maybe they got alcohol in deployment and you don't have good access to benzos or a way to monitor them, we used to step people off with alcohol. So we actually used to carry like Bud Light and stuff like that on formulary. And essentially, if they were drinking 20 drinks a day, we'd start them off at 15, and you just slowly bring them down and slowly cut down the amount of alcohol that they have, right? It's a safe way to detox somebody. It still works. Good. Remember, these are your hallucinations, your illusions, delusions. There are a difference between them. And that's just that quick reminder for you all. And that's your pink box criteria when you're talking about alcohol withdrawal. So we have use disorder, withdrawal, and intoxication. So make sure you're not getting those mixed up. Biggest thing would be don't mix up the intoxicated state with somebody who's going through a withdrawal state. They have to be treated a little bit differently. One, we treat with just supportive care, like, hey, you open the finish, you're drunk. The other one, we actually want to treat with meds, monitor for those DTs, that seizure and stuff like that as they withdraw down. Good. I think I've covered all of this already. Yeah, I would say just from a clinical aspect, have a very low threshold to send somebody up to the ER if you are worried about withdrawals. It's only about like 1 to 2% of the population of alcoholics are actually going to have DTs and seizure. But it's one of those ones you don't want to necessarily mess with. But a lot of times, so low threshold, but we can manage a lot of these guys on the outpatient side with meds and therapy. Good. Yep, I'm good with that. Cool. We've already talked about a lot of this already. I've already talked about that bottom one. We're talking about how they presented to the ER. Good. So this is actually kind of a good point. And I'll tell you guys the easy way. This looks super complicated. Here's what I'll tell you guys. When you're getting your history, it's super important to ask how long it's been since their last drink. Okay? So if they've gone 24 hours and they're only having like a little bit of sweating, maybe a slight tremor, a little bit anxious, that's actually a good sign. They've gone 24 hours without a drink. That's a good sign that this person can probably be treated on the outpatient side. If they've only been able to go like 3 hours or 4 hours since their last drink and they're already having the shakes, they're already tachycardic, they're already having some confusion, that's a bad sign. That usually means that person's going to have a bad withdrawal. They probably needed to go to the ER time down. So whenever you're dealing with these people, ask them when their last drink was. Try and get a time frame associated with it. And a lot of times also with alcoholics, they recognize that the condition is bad, so they've tried to quit on their own. Just ask them, like, hey, have you ever tried to quit alcohol on your own? If you did, how did it go for you? How long were you able to go? If they're like, man, I tried, but I was only able to go like 1 day without my alcohol, that's a bad sign. If they're like, yeah, I was able to quit for like 2 weeks without a drink, usually a good sign, reinforcing that, hey, this guy can be managed in the outpatient setting. So you can get this full chart just based on talking with the person and asking like 2 simple questions, right? Good. The next up, coffee. Again, intoxication. You'd have to be taking a ton of caffeine to cause all of this. This is usually where I see, believe it or not, pre-workout is where I tend to see this a lot more because it has a lot of the caffeine that's in it. And I'll have I actually had this on deployment a couple times. There's nothing you really do. But essentially what my soldiers were doing is they'd be drinking energy drinks throughout the day. They'd have their coffee in the morning. And then we'd be getting ready to go to the gym because there's nothing else to do. And they would be basically dry scooping their pre-workout powder like C4, Jack 3D, or whatever it happens to be. So now they just had a crap ton of caffeine throughout that entire day. And they would be kind of like amped up in the gym, twitching. They'd be like running away to go poop themselves. And that's what you kind of see with that caffeine intoxication, right? On the bad side, because you are giving them essentially a stimulant, you have to take it a lot, but you can cause some of those arrhythmias and stuff like that when you are talking about caffeine intoxication. But not super common. Generally, I'll see it kind of in that. A lot of times they're taking a bunch of different things that contain caffeine and they just don't realize it, right? Especially because if you guys look at the back of your energy drinks, like those Monsters, the Bangs, not Red Bull's not too bad, but if you look at the milligrams of caffeine contained in one of those drinks, a lot of times it's like 100 to 200 depending on the drink, right? But you're already kind of sort of hit that 250 milligram. And then if you're having multiples in a day, all within a short period of time, that's where we start to run into those effects. Good. That's your intoxication. Never stop coffee, though. I will say that. Obviously, you stop the caffeine, and then really you're just offering supportive care, right? We're just making sure that they're okay, making sure that they're not having a cardiac arrhythmia, something crazy like that needs to go to the ER. But there are no magical reversal agents. There are no like meds to reverse it that we're going to step them down off of, right? Good. Yep. I've never seen somebody take 10 grams of caffeine. That would be intense. That's a lot. Good.
Gotta do what you gotta do.
So there's your chart talking about energy drinks and how much they happen to have. Does anybody even drink rock stars anymore? I feel like that's early 2000s. You guys are all about Celsius. And, what's that? Yeah. I don't think rock stars are a thing anymore. It's all about Celsius and Bang now. That's like the new big trend.
You need to replace that with a white monster.
White monster. Fair. Alright, so caffeine withdrawal. So caffeine withdrawal, this is, again, you're thinking about how they are in that active state. Now you're kind of getting into the exact opposite, right? So headache is a big one. A lot of times, because caffeine is an energy. Now you're having fatigue, drowsiness, you're kind of sad, irritable. We've all kind of gone without our caffeine before if you're a big caffeine user. And these are those symptoms that you're having, right? Again, usually you have to be consuming a ton of coffee to hit the nausea, vomiting, muscle pain, the flu-like symptoms. That's usually a lot. These ones are the big common ones that I see. That's why I don't stop drinking coffee, because I've legitimately had this before, but it's not a problem because it's not affecting my personal life. So it doesn't rise to the level of a disorder.
First step.
Good. And there's your big box going through there. I don't have a problem with it, you should admit. Again, that headache is going to be that hallmark feature, and usually the patients will tell you, like, yeah, I have to have my coffee within like 8 or 9 in the morning, otherwise I just have that headache, right? Believe it or not, I usually haven't really treated caffeine intoxication withdrawal all that often. Usually it's along the lines that the person's dealing with something else and they're trying to cut back this in their life, and then they have the symptoms. You just tell them, like, hey, yeah, you're just having withdrawal from your coffee. Ibuprofen, Tylenol for the headache, kind of that supportive care is really all that you need, and you'll be fine. Or just never stop. Good. All right, now moving on to marijuana or cannabis. Again, if you're looking at the first grouping, so you only have to have 2 in the 12-month period, that doesn't really change. So I'll hop on my soapbox a little bit about cannabis since we're over good on time. So for the average person who's just run-of-the-mill Joe Smo on the streets, believe it or not, cannabis, marijuana, it's pretty benign, right? It's not truly one of our addictive substances. You're not going to be like craving. If you take anything in excess, it can obviously become an addiction, but that's just the same as like gambling or work. Anything can become an addiction in your life, right? This is the same with cannabis, but it's not one of our really bad ones like we're talking about with like alcohol or methamphetamines or cocaine, right? So for the average person, it's pretty benign. Where cannabis starts to become a problem is when you already have a psychiatric disorder. And this is where I hate when people are like, oh, I take cannabis for my anxiety. Like, you're making things worse. Because what cannabis does is you're basically snowballing yourself. So you're now just numbing yourself to your emotions. So it's not allowing you to process what's going on. It makes my therapy much more difficult because every time you get into a difficult state, you're just running off and smoking the joint rather than addressing it. And now you feel better, right? Yeah, because you're numbing yourself. You snowball. Or if you're dealing with like psychosis, schizophrenia, bipolar disorder, THC, because the psychoactive component makes everything so much worse and so much more difficult to treat. Cannabis kind of became legalized and everybody made the argument, oh, we all did it in the 60s and 70s. Like, yeah, you guys did it in the 60s and 70s, but the THC percentage back then was really like 13%, 15% of the plant was THC component. Now, because it's become industrialized, right, and anytime something becomes an industry, now all of a sudden we want to get better and better with it. You're talking about your average strain for cannabis is sitting between like 25 to 30% THC. So your component of the psychoactive, significantly higher. And then when you're talking about different formulations, so something that is a gummy or a food, when you're baking it and distilling it, you can start to get to that 40 to 50% range of THC, which is a lot higher in the psychoactive component. And then when you're talking about dab, do I have any Colorado here? Did you ever have to deal with anybody who was on dab at all? Yeah. Dab, like, what's that? Oh, do they? Yeah. Dab is crazy. Dab is like 90%. They can't get to 100 yet, but it's like 90% THC, and it's all a psychoactive component. So they're having people go into a psychotic break simply because of marijuana and the THC component. So if you have a family history of schizophrenia or one of those other psychotic disorders, and you're using marijuana, it actually puts you at a 5 to 6 fold increased risk of having your first psychotic break. right? All because of medication, sure, a substance that you added on, right? If you're just the general population, it's really only increasing your risk about 1 to 2-fold, right? So it definitely raises the level, but not nearly as bad if you already have the psychiatric issues, okay? So marijuana, just for the average person, not too bad. But once you start to enter the mental health field, this is one of our big issues that we deal with. So if your patients are telling you, oh yeah, I just use a little bit of THC to manage my anxiety, please be like, you need to stop that. It's making it worse, actually. They can have that rebound anxiety, right? CBD is actually a little bit different. CBD is not the psychoactive component, it's more the inflammatory component. It hits a different receptor. You have CBD1 and CBD2 within your brain. CBD2 tends to be more in the gut and the body. CBD1 tends to be more in the brain component and the central nervous system. That's why THC loves CBD1 receptor. CBD loves CBD2 receptor. So that's where you kind of get the munchies and stuff like that. That classic, oh, you crave food and stuff when you're high. That's more the CBD component, and it's hitting a different receptor in your gut. So for things like patients who are on chemotherapy and they just can't eat because the chemo is so bad, marijuana for them, if it's more that CBD component, actually has some benefit to it. Like there's some good data behind that. So I'm actually more interested in the CBD component than the other half. But just realize there is a difference between the two. It's probably more than you want to know about cannabis, right? At 10 in the morning. But getting off my soapbox about cannabis now. Good. That's pretty much everything that I just said, hopefully. Yeah, good. All right, cannabis intoxication. So think about Scooby-Doo, Shaggy. Shaggy was high. I'm telling you that now. I'm sorry to ruin your childhood. Think about Shaggy, right? Increased appetite. They always have a high heart rate. That's that red eyes that you're seeing with cannabis intoxication. Okay. 2 hours of use. Yep. Good. Synthetic cannabinoid, this has kind of died down a little bit, but they're still floating around in the market. Synthetic cannabinoid is crazy. That's where you're kind of getting more into your Delta 8, Delta 9, kind of not so much bath salts, but kind of it's the stuff that you're buying at the gas station, right? Don't buy your drugs from the gas station. If you are going to do drugs, don't buy it from a gas station. Buy it at a minimum from a dispensary, right? It's a little bit safer. So essentially how this happens is marijuana has been illegal at the federal level, but what you can do is you can make a synthetic compound that mimics it and still attacks the same receptors. Well, the synthetic compounds aren't illegal because we use them for a bunch of different things within multiple different industries. So I can buy the chemicals, process them at my house, my shop, package them, and then sell them, right? And now all of a sudden I have a synthetic opioid or synthetic cannabinol. So that's what manufacturers were doing. They were doing it like in China, Mexico, in the US as well, and they were just getting shipped in, and that's how they were finding their way on gas station shelves. So then what happens, lawmakers will go in, we can't ban all the chemicals because we're using them in multiple industries, so they'll ban one specific component, right? And then what will happen, because drug dealers aren't dumb, is they just go and they change the compound, and now I'm doing the same thing and it's legal again. So that's what when you're seeing this stuff in the gas station, you're like, how can they possibly sell this? They're just changing the chemical formulation, and now it's legal, and they're constantly chasing each other to try and legalize it and not legalize certain things, right? Oh, they don't have the one up there. There's another one out there that's pretty crazy. It's Blue Lotus. I don't think it's a cannabinol, but it's in the same realm as bath salts. I've had multiple patients who've used that one, and they go straight into like a renal failure. It's crazy. The side effects aren't one you want to mess around with, right? So cannabis withdrawal, again, you're kind of starting to see that opposite, right? So cannabis itself is kind of a numbing agent. It knocks you out, it makes you tired and sleepy, so you're seeing the opposite. Increased irritability, anger, their anxiety is worse, maybe insomnia because they were the classic way I'll see cannabis used is it helps them sleep. And then when they stop using it, now they can't sleep anymore. Decreased appetite, so maybe a little bit of weight loss. Depressed mood, because again, they were kind of using it to snowball themselves. Now that mood is coming back. And again, you kind of start to get that GI stuff because those CBD receptors, remember, they're in the central nervous system and within the gut itself. Good, good. And And a lot of times, again, there's no real med that we're gonna use for cannabis withdrawal. A lot of it's just kind of focusing on that symptom support, giving them some meds for the headache, helping them with their GI symptoms, kind of more that reassurance. There is no medication I'm gonna use that's gonna block their CBD receptors and help with their cravings and stuff like that. Naltrexone, believe it or not, we kind of use it in multiple different scenarios, even though it's not FDA approved, but it tends to have a lot of help with craving symptoms. That's why we use it for alcohol, opioids, weight loss, because it kind of helps with that. So if you really had to go with one, you could try and experiment with that to see if it helps. Good. Cannabis, all right. Now we're kind of getting into the hallucinogens. Starting to get there. Again, 2 through 12, no major change we're seeing on that slide, right? So we're pushing on. This is your hallucinogens. This is like your PCP, right? The PCP is crazy. People do some crazy stuff on PCP. It's basically like you're giving them a crazy brief psychotic disorder, and they're miscuing on the environment around them. They can become like kind of really hostile and angry and stuff like that. Not as common because it tends to be one of the more heavy hitters, but you'll definitely see it out there. A lot of times with this one, what you'll see is that nystagmus, analgesia, so they don't feel pain anymore. And then that hypertension, that really bad high blood pressure. That's why when you tase these people, or the cops are tasing them, and you see them take like 3 or 4 tasers, and they're still not going down, it's because of that analgesic effect from the medication. They're just legitimately not feeling pain. Good. Yeah, so a big kind of what sets this condition apart from the others when you're talking about that acute intoxication stage is this hyperacusis. So they really are very reactive to sound, right? And then of course you're dealing with that decreased pain feeling, and the nystagmus will actually change with these. When you're talking about alcohol, it's usually going to be that horizontal nystagmus, that back and forth. With this one, you can actually kind of start to see that vertical nystagmus. So it's actually a little bit different. Either I will go to the corner and start ticking up. Okay, those are kind of what sets this intoxicated state apart from the other ones. So when you guys are studying, definitely pay attention to the intoxicated state and then the withdrawal state, right? Because I'll ask you questions about them. You got to know those symptoms and how they present, so you know what you're dealing with in the ER setting, family care setting, whatever that setting happens to be. Good. So there's your PCP. Not super one of the big common ones. Not really a party drug or anything like that, but definitely still out there. Good. This is your other category. Believe it or not, you can huff and puff a bunch of different things that'll get you high. They're all about the same. Air dusters can do it. Gasoline can do it. Paint can do it. Like you can get high off a lot of crazy different things. I don't recommend it, but you can. Please don't go home and leave or go to your shed and start huffing paint. Like after my told you to, I did not tell you to huff paint. What's that? Right. So this is where you kind of get into the psychedelic effect. These are your other ones, MDMA or ecstasy. This is kind of like your catch-all category of other things that we don't have a set differentiation for them. The biggest list that you'll see from these, the one I have the most kind of limited experience with, I didn't take it personally, is MDMA or ecstasy, right? That's your classic party drug. It's still pretty relevant, especially in like the college scene. That's the one that puts you in that really euphoric state. You make really close connections with people. Also make you super hyperthermic. Could be categorized as a date rape drug depending on the person you're talking to and what criteria that they're using. You'll definitely see that one out there as well. And this is actually MDMA when we're talking about PTSD. This is one of these things that we were looking at as a treatment for PTSD, because again, we're helping those people create a connection, right? It's still in phase 3 trials. There's a lot of issues with the trials that are ongoing, which is why it doesn't have FDA approval yet. So please don't go buy Molly off the street and start treating your PTSD patients. It's not approved. You have to wait. Good. So We're going to talk about intoxication, 2 or more of these symptoms. With these ones, you're actually going to see a lot of that pupillary dilation. So the pupil gets really big and wide, whereas a lot with our stimulants and with alcohol, it tends to kind of sort more towards that narrow side. Tachycardia is pretty similar to a lot of them. Sweating is pretty similar to a lot of them. Tremors, incoordination, blurring vision. There's not a whole lot that sets this out apart from the other ones. The big thing is going to be the pupils and like the sweating state and kind of like the agitated state, right? Yep, good with that. This is actually kind of interesting. So essentially what's going on with this is you fried your brain and you've taken so much of it, you're having flashbacks or you're having, it's what's called known as like having a bad trip, right? That's what they're talking about with that. This usually happens because just genetically, you're not supposed to be taking that. And you're just more predisposed to having a really bad hallucination or a bad trip with that. When you're talking, that's why the problem with psilocybin, we always want them to be in a very controlled environment. So you don't want to have somebody who's like super high and then put them in the pediatric room because they have all the stickers and stuff on the wall, right? Well, now those stickers are alive and looking and talking with them, they can freak your patient out. So anytime you're dealing with somebody who's on a hallucinogen and they're intoxicated, you want to put them in a subdued environment, in a calm room. You want to be careful with what's going on around them because you can freak them out. Good. Okay. Good. I don't think I need to touch on any of this stuff. I think we've already called it. There's so much stuff out there. That's why alcohol, addiction medicine is its own subspecialty, right? Good. I think we're good with that. Biggest thing we're doing with this, again, there is no reversal agent. There's no medication that we're going to use to cover for them. You do, if they're having the agitation, benzos are going to be your big one to go with that. If you're worried about the hallucinations and you're kind of hitting more on that psychosis, you can also add on with antipsychotics to get them in that calm down state until you can figure out what's going on with them. Good. Inhalants. Sorry, I miscued. Inhalants, these are the ones that you're huffing, right? Sorry, I told you to huff paint too soon. Now you can huff paint. Good. Good. Again, intoxication state. This is what you're talking about with this one. We're kind of setting this one apart and making it unique from the other ones. And now you're looking at the depressed reflexes. So when you're hitting them with the hammer, you're getting no reaction for that if they're letting you get that coach. Generalized muscle weakness. So now the entire body is going to be weak because you're messing with the airway and causing some problems with that. Stupor and a coma. Because again, you're messing with the airways, maybe they're not getting good airflow going on from that drug, and you actually hit that stupor and coma state. And then euphoria. Again, if you're restricting your airway, your brain doesn't necessarily respond super well to that, and then you can actually start to hit that euphoric state. The same thing's now going on because of the hallucinogen drug, right? That's kind of where you get into never mind, talk about that later. Good. Any questions about the inhalants or any questions so far? Trying to buzz through these pretty quick because it just comes down to you got to memorize the intoxicated state, withdrawal state, because otherwise the use sort of kind of stays pretty much the same. Good. Huffing. Actually, so this is why I actually did have a patient who was doing this, but they were doing it with dust off. So essentially, that's why they added the bittering agent to the dust off, is because people were huffing that and basically dying from it. So this guy was actually abusing the dust off and basically kind of giving him that oxygen deprived state to get himself high. It doesn't last for very long and it's super high risk. But patients still do it. Another one you might see is called whippings. When you're dealing with like the whipped cream in the can and stuff like that. That's why when you see a bunch of high schoolers buying a ton of whipped cream for some reason, you're like, what are you actually doing with that? They can actually, I forget how they do it, but essentially you can mess around with the valve and then you're just getting all of the aerosolized and none of the cream that's in there and getting yourself high. All right, opioids. Opioids are a pretty big problem. It was a self-made problem, but it's not all of our fault. It's not all the insurance providers' fault. Like, don't ever think patients didn't have a part to play in this, right? And now we're kind of on the backswing of that. We're dealing with those repercussions. So originally, this kind of started with the Purdue family with pharma, right? And what happened was we all said, like, hey, pain is the fifth vital sign. We all need to address pain. We need to address pain. So we were over-prescribing opioids for a lot of these patients, and they worked. Opioids definitely control your pain control. But patients were then getting addicted to them, because originally marketing came out, they said they were non-addictive, but that was a lie. You're hitting those opioid receptors, you feel really good when you're on your opioids. And then they keep going with them, they keep needing them, and anytime you try to stop, they get a really nasty flu-like symptom, their pain starts to come back, so they keep going with it, right? Well, eventually, us as providers, we cut them off, right? Okay, no more opioids for you. So then what happens is they go, okay, well, that's fine. And they start buying heroin on the streets, right? Heroin you can get for like $25 for a dime bag. It's pretty cheap compared to opioids. So then they start using their heroin, right? Then what happened was the heroin was getting cut with fentanyl. Because your drug makers, they really don't care about patient safety, believe it or not. And they can cut that heroin and they can add more to it, and that's when you start getting fentanyl mixed in there. People were dying because fentanyl is crazy strong compared to just the normal heroin. So these patients were using their normal dose like they were supposed to, but now you have something new cut into it, and they were overdosing and dying from that. That's why fentanyl became such a huge issue, and you're hearing a lot about it in the news right now. So opioids, it's always changing and manipulating, because patients are still going to be in pain. They still want that drug. And you'll definitely this is something you'll definitely see on the provider side. You guys are going to have drug seekers. You'll have people that want opioids, and they'll be especially if you're on the civilian network, you see a lot of doctor shopping. So if you see somebody who's had like multiple encounters for like severe pain, and it's all within a very short time frame, that's a higher likelihood that you're dealing with a drug seeker. If you're in the ER, patients aren't dumb, and they know our networks are not connected. So they'll go from one hospital to another hospital to another hospital to get their fix and get their opioids, right? A good example is if they have nondescript pain that just doesn't respond to anything. You'll give them a Toradol and it's like 10 out of 10, right? You'll give them IV Tylenol and it's like 10 out of 10. And the only drug that works for them is that drug that starts with D. It just happens to be Dilaudid, right? Don't think that every single patient that comes in is always drug seeking, but you're definitely going to encounter it on the primary care side or in many of the specialties, right? Know what your state's prescriber monitoring board is. You can actually log in and you'll be able to track if stuff is being updated correctly, and if your state has a good one. You'll be able to track where that patient's been, what prescriptions they're receiving. If you have a high concern, you can do a little bit of research and kind of investigate further. Yep. So when you're talking about intoxication, this tends to be, again, remember, out opioids, they're going to snowball you. It tends to have that drowsiness, that coma, that slurred speech. They can't really concentrate. They can't really pay attention to anything. That's your acute intoxicated state. That's where your person kind of is doing that nod off and they're nodding on the heroin. That's what they're talking about. You're making someone super tired to do with the opioid. Good. Opioid is when you constrict, get really narrow with this one. Again, that kind of sets it apart from the others. Is how that people is going to present. Opioid withdrawal, now you're getting into what's going to be the reverse, right? So with this one, they're going to be nausea, vomiting, that GI stuff, because again, the opioid receptors are within the gut and everywhere within the body. We have multiple different ones. So a lot of times the GI symptoms are what they're coming in complaining of, right? Then they're having diarrhea is a pretty common one. Now the people are going to be dilated. Pyeloerection, so that's where the skin, the hair on your skin actually starts to sit upright. It's something that's very unique to the opioid withdrawal. We don't really see that with our other disorders, right? So that's something that sets it apart and makes it unique. Good. Opioid withdrawal. All right, so going into our treatments. So the same drugs that we use a lot for our alcohol withdrawals are very similar. So a big one being that naltrexone. That's the one that we like to use. And then naloxone, if you're worried about that with overdose state, right? In that ER setting or that acute setting. Remember, don't mix the two up. There are some other drugs that are out there as well. That's where you kind of start to get into methadone can be used for it. Methadone clinics are a big thing. buprenorphine is another one. Those are very high-end drugs. You have to kind of be specialized and have received additional training in those, but they're very effective for opioid patients as well. All right. Take a break for, I think we're pretty close. We're pretty close. Take like a quick 10-minute break, and then we'll finish this bad boy up. Just because I need to pause for a second.
Yeah, there's a couple of those where I like sodium, but then no potassium urine. Yeah. Remember, sodium will go out of the cell, potassium will go in the cell, and then vice versa.
I'd be ashamed to do something on it. Wood boxes.
It wasn't even
Last like 2 inches. That's probably really. Here's the week before. I just think next week is our last before tournament. Please. We have to the makeup game last week. Because
So you could do that.
so we were 2 hours.
Okay.
Well, after this one,
Everything in volleyball is sexual in nature. So we're the city brings it up, and then yeah,
I like to like small play. Okay, that's for sure. 2, 3 hours, and then she's it's not hard, and I'm not like killing. There is a part in the hospital where I go like,
I'd rather, I'll probably just do first time. Yeah. It works out better for us to play.
Feel it?
I bit my.
Oh. Yeah, I've done that a couple times.
There's only two. Got his money right. I really don't think
I know why you like BJJ. You like folding clothes with people still in.
Oh yeah. I thought we were gonna go a different way, and I still would
So they just announced like 40 airports across the U.S. are canceling flights because of so like I don't know if the airports are on there or not. But flights are already announced that they're not canceling. So they're cutting 10% of flights because of the reports that working. I mean, it's good. I was just saying, like, just watch it here. Both of them, like, your return and your departure flight. I would also be coming back and get the MIA super early because Trump isn't running over so it might be extra traffic.
I would imagine you would be flying.
No, it's just
Well, I know it's
no, he likes it. He goes to Southcom, which is like those airports there, kind of like the smaller airports. He flies in that. Yeah, but like he was like he's already there.
Yeah.
So most likely he's flying. Because I'm going to fly airports right now. I feel like
Alright, so that puts us right at 10 minutes. We're almost there. This is a lot. I normally don't like doing this much, but we have a 4-hour block. We all want to use it. We will make it happen. Especially with this stuff is involved. Alright, so real quick down here when they're talking about naltrexone may result in accidental overdose. This is because naltrexone, the opioids, tend to last longer than the treatment itself. This is why a lot of times they're going to need multiple doses. So what will happen is that person will give them the naltrexone. They'll come out of that overdose state and they'll be perfectly fine because again, all those receptors are now displaced and blocked. But that naltrexone is going to wear off, and then those opioids still in the system, so they'll go right back into their overdose state. That's what they're talking about. That risk for accidental overdose is so higher because now I think you can buy this over the counter. I think you can see it at Walgreens. Like we try to make this as available as we can, but patients don't necessarily understand how to appropriately use it. That agent is made to reverse the scenario that they're in, but then they need to go and get help or be prepared, or they need to be prepared to give multiple doses of that quick-acting reversal agent. That's what they're talking about with that one. Right? So now we're going into our sedatives, our hypnotics, and our anxiolytics. So this is going to be your benzodiazepines. That's like your big category for this one. Not super common to abuse benzos because there's no real aftermarket that's comparable to it. But patients will still get them prescribed. There's still plenty of pill markets that are out there. And providers, depending on the person that care more about the money, they'll be prescribing these as a pill form and giving patients a script for this. So you still see it out there. Again, this not really going to change. It's pretty comparable to all of the other disorders, right? So it's going to come down to what are they abusing. Now I can make that diagnosis. Good. Okay. These are going to be your big ones. Barbiturates, not as common on the market. Barbiturates are definitely in that date rate category. You can still kind of find off-brand stuff depending on just your home chemist and whatever they're making, but we really don't see barbiturates as much, right? But definitely on that benzo market, you're seeing a lot of those. And again, what you'll find as we start to go through these categories is this is going to sound very similar to alcohol because again, we use one to treat the other, so we're going to see a lot of similarities within the system when we're talking about intoxication and withdrawal. Good. So slur speech and coordination, unsteady gait, nystagmus, this all sounds very similar to somebody who's alcohol intoxicated at the time. The one thing you don't see as much with these as you can see with the alcohol is that hallucinations, that psychosis that you can see with alcohol use sometimes. You don't get that as much with the benzodiazepines. Okay. There's your pink box for it. Stupor in the coma is going to be a big one with these because it is that sedative agent. So if they're taking a lot of it, it'll drop them into that coma state, that respiratory depression. That's where you start to have to worry about trying to breathe for them or giving that reversal agent. Believe it or not, we actually can cause the intoxication on the medical side, right? Sometimes we can cause this because we're hitting them with an agent, they're not calming down, they're being angry, they're being agitated, so I give them more. They're still not calming down, they're being angry, they're agitated, so I give them more. Now all of a sudden I've given them 4 or 5 doses of diazepam to get that person to calm down in the ER. Now they're in that intoxicated state, and now all of a sudden I have to worry about the respiratory system because I've given them way too much of the agent, and now I have to breathe for them, right? So a lot of times we can actually see this in the medical side too, because we do it ourselves. Good. Memory impairment, again, very similar to that alcohol when you're talking about memory and cognition, because we're hitting a lot of those same receptors. A lot of times patients are also abusing multiples, so then you get a stacking effect. So they're not just on benzos, they also happen to be using alcohol, they also have some opioids, and then mix these all together, and now you get a stack on a lot of these conditions, and it makes things a little bit worse as well. Good. So Now you're talking about how does the withdrawal look? Again, very similar to the alcohol, right? It's kind of hard to differentiate the two. There's nothing that really kind of makes them stand out. You're still going to be worried about that seizure is going to be the big one with your benzos and with your alcohol. So you still have to worry about that as well. So a big part with this is getting that urine drug screen, that you're all getting a good history of what's going on, asking them what they took. That's going to be help kind of clear and differentiate the two together. All right. Good. So we do actually have a reversal agent for benzos. That's flumazenil. We don't want to use it unless we absolutely have to, because there is that increased risk once I give the reversal agent that I can send somebody into a seizure, right? And if they already have a seizure disorder, it increases the risk. And if they're already abusing alcohol or benzos, that seizure disorder is dropped already. So there's that risk I'm going to send them into a seizure and make things worse for myself. So a lot of times our approach to anything to do with benzos is we're going to just monitor over time and see if they're able to do it on their own, or if we need to give them a little bit of oxygen, or if we need to breathe for them. That's generally what they do. Because essentially, for you guys who know your RSI drugs, what's one of the RSI drugs? Well, yeah, so fair enough. Okay, sorry. There's no formulation, but a lot of times we're adding a benzodiazepine to that formulation for our rapid sequence, right? So they've already basically taken one half of the rapid sequence. So if their airway is completely going kaput, well, I might as well just intubate them until they calm down, right? So that's a lot of times the approach that we take rather than giving this reversal agent. But we do have that option on board if we need to go that route. You just got to be prepared to manage the other effects from that. And this does not work for alcohol or any of the other stuff. It's only unique to the benzodiazepines as far as reversal agents go. Good. So that's our sedative narcotics, that's our benzos. Very similar to that alcohol, just kind of know it does have the reversal agent. That's what makes that one unique. Otherwise, nothing too much. And then we're going to get into our stimulants. So our stimulants, that's going to be everything like cocaine, that's our methamphetamine, that's our amphetamine, anything that's amping you up and getting you going, right? That's going to be the stimulant category. So what's unique to the stimulants is that you can develop a tolerance and like almost an addiction rapidly or pretty quick with these ones, as opposed to some of the other ones that can take a few months or multiple amounts or can take a lot of alcohol to kind of hit that addiction category. With these ones, you can hit this disorder pretty quick after starting a stimulant med. That's why we are very careful with our amphetamine drugs, like our Ritalin or Adderall. That's why you have to jump, one of the reasons you have to jump through so many hoops before you can get them prescribed, and you have to make sure we confirm the diagnosis of ADHD, because the abuse potential with those drugs is there, and a lot of patients want to be prescribed them, because it does legitimately help you study, it helps you focus, it does a lot of that stuff, but you're abusing it at that level. All right. Again, remember the withdrawal of the drug is going to do the exact opposite. So with these ones, we're putting you in that amped up state because it's a stimulant. You're going to hit a pretty hard depressive state if you come off of that drug. So you have to be aware of that and kind of monitor for that. But it's not as bad as a major depressive episode, right? So it tends to resolve a little bit quicker. Remember, you need 2 weeks for major depressive disorder. A lot of times these symptoms will resolve within that 1 week. So it's a much shorter time frame, but it can be just as intense. Something to warn your patients about and be aware of, right? So with your stimulants, it's kind of unique. It can be tachycardia or bradycardia. I tend to see tachycardia more than the other one. And then you're seeing a lot of that nausea, vomiting, again, those GI symptoms, that elevated blood pressure tends to be there. But this is kind of unique towards the bottom where you get that dystonia, that dyskinesia, that seizure. Again, that's kind of unique to our antipsychotics, but we're now seeing it here with this during that intoxicated state. Agitation tends to be pretty much there when you're using these because you are giving somebody something that's going to make their anxiety worse if they already have that, right? Otherwise, as far as like what makes these unique, cardiac arrhythmias and chest pain, so you are going to want to check with that EKG. But rather this other stuff, you'll see this with multiple different ones. Weight loss, that's going to be with long-term use. A lot of times we think about a meth head and how they look on the streets. They're like, the intention's bad, they're super skinny. Because when I give you a stimulant, it suppresses your appetite, right? That's how phentermine works, right? You're suppressing somebody's appetite, so they're not eating. So you tend to see this more with the long-term use rather than only a week or two. This is somebody who's been on their stimulant for a while and they're just not eating because they're not hungry. Okay. Good. I don't think I need to touch on anything else with that one with the intoxicated state. Good. Again, that's where there's a lot of overlap with a lot of these conditions with schizophrenia and with psychosis, and that's why when we talk about that in the next block, we always start with a brief psychotic disorder. That's going to be our initial diagnosis, and then if you get better, you don't ever advance to that diagnosis of schizophrenia, right? Whereas if it becomes progressive and more frequent, now I can make that diagnosis. So that's why we kind of use a general one when we're first diagnosing, because there is a lot of this overlap with these substances, with these other conditions that aren't necessarily associated with that. Another thing that you'll find, unfortunately, if you get into the psychiatric field, is our patients who have psychosis, schizophrenia, schizoaffective, personality disorders, a lot of times they're abusing their drugs as well. It's just they kind of cohabitate together. And it almost kind of comes down to the argument of what came first, the chicken or the egg, right? Did their substance abuse history trigger their psychosis and then developed into schizophrenia because they were at risk? Or did they have schizophrenia, they were picking up on it, and then they were taking something to try and combat that because they knew they weren't right, so they just happened to turn to street drugs, right? I don't think it matters too much. That's why the high-end specialty exists. So if you're trying to deal with that scenario or trying to figure out if it's a drug or a condition, that's where we refer over to behavioral health, have them get involved. Biggest thing you can tell us is like, hey, like he's popping positive for this, but he has this weird history of this going on over multiple years, right? So make sure you're getting a good history with that. Similar with withdrawal, it's kind of going to be the exact opposite. One of the things that's unique is you do tend to get some crazy dreams when you're coming off of your stimulant. So patients will complain about very vivid dreams, really living very significant situations that are very like aware to like almost reliving it in that moment. So that is something that's unique. And again, obviously we've been suppressing their appetite for so long. Now all of a sudden their body's having that craving again. So now you have that increased appetite because the body's telling them to eat because they're in a caloric deficit. Your body's trying to keep you alive. Your body's amazing at doing that. And it can happen pretty quick. So this is kind of unique to the stimulants is again that euphoric mood happens relatively quickly. Same with your withdrawal symptoms, it can happen within a few hours of stopping that stimulant bed. It tends to hit pretty quick, but it also burns out pretty quick too, if you can get somebody to push through, which is hard. Good, there's your pink box for it. Nothing too crazy on that, kind of reinforces what we've already talked about. Good, that's your crash that you're talking about, your runs and binges. So again, somebody will have a use of it, then drop off, and have a use of it, and then drop off. That's a binge or a run. Good. So this one, it does, interestingly enough, we do have an agent we can kind of use to help with that. That's your bromocriptine. And it actually does have some benefit to the cravings, right? So that's the drug that makes it unique, where we have an actual substance that we can use to treat with another drug. We only had alcohol was another one, and opioids were really another one, right? So this is something that's unique to this drug. It's okay. I think it's unique to just cocaine, so I don't have much experience with this one, just because I don't see a whole lot of cocaine in the military population. It tends to be other grouping. Otherwise, if they're in that psychotic state, you treat it exactly the same. You're going to hit them with those antipsychotics. As with all of these substances, if we can put them in with a group, they tend to have a better reaction because you're having that community support. That's why those programs exist. So otherwise, the treatment program, the algorithm kind of stays the same, right? With the unique thing on this slide, that bromocriptine that we can use in those scenarios, okay? Tobacco. All right, so tobacco is another big one, and you'll see this a lot, and especially in the primary care setting, you guys should definitely be comfortable with your tobacco meds and be comfortable initiating that treatment. Everybody loves to say, oh, I'll refer to the tobacco cessation program, and they'll take care of it all, right? Not so much. Usually that's only one or maybe two providers that actually have that training, if at all, and their schedule gets crazy backed up. So a lot of times we depend on you guys to start that initial treatment because the medications for tobacco are just as effective as the therapy, right? Once I can get somebody to stop the tobacco, I can have success. So you guys gotta be familiar with this and checking with those drugs. Please don't just punt to behavioral health. They'll fill up our log with all sorts of stuff that maybe necessarily shouldn't be there. Okay. Cigarettes are actually still the most common. We still see that a ton. And then vape pens, vaping, it's starting to creep up there, but it's kind of stabilized. We're not seeing that huge rise in there as much. Chewing tobacco tends to be pretty much regional. Within the military, I actually see a lot of the chewing tobacco because it's something that you can do to keep yourself awake, especially if you're standing guard, you're on mission. It's something you just do. You don't have to worry about smoking and stuff like that. So I tend to see chewing tobacco in the military a little bit more than this, a little bit more than the vaping and stuff. But cigarettes are still the big one. Good. Associated smoking behavior, again, that's pretty straightforward. We've all seen this. You guys have all seen the smoke pics and stuff like that. And again, we all know the bad side effects of tobacco and the nicotine. Most of our patients are aware of that as well. So really, every time you see them, you don't need to harp on the cardiovascular. We all know cigarettes are bad. We all know tobacco leads to cancer. So really, it's offering that person a chance every time you see them. Try and plant that little seed in their head that they should quit. Because most of us recognize we need to. We're agnostic about it. We don't really care. So if you can get that one opportunity, you're going to see these people multiple times. Maybe actually get them to quit on the 4th or 5th episode and actually initiate treatment for them. Right? So your withdrawal symptoms for tobacco, so that irritability, frustration, difficult concentration, restless mood, depressed mood. That's pretty common. It's very similar almost to like the caffeine when you're talking about withdrawal from that. It's usually not too bad. It's just patients tend to be irritable, they tend to be angry, and they can be a little bit anxious when you're stopping your tobacco, right? Because again, you're having those cravings for it. It tends to represent itself. And it happens pretty quick when you're stopping tobacco as well. If you're missing your cigarettes, it tends to start. Good. Good. Yep. So remember, nicotine is an appetite depressant, so that's why they used to issue it in the C rations because you can go longer without needing food. So when somebody stops their cigarettes, now all of a sudden they can start to have that craving for food again. They can actually tend to overeat and stuff like that. And because it is a little bit of an activator, you can start to have that impairment when you're talking about vigilance, concentration, and stuff, just because the med's not there anymore. Good. Dreamings and nightmares, nausea, sore throat, coughing, constipation, nothing too crazy that sticks out from that differentiate, but that's what we're seeing with alcohol withdrawal, right? Yeah, that's just because, again, cigarettes are easy to get to. They're legal, so that's why a lot of these patients, they're just supplementing one substance for another, and it tends to be tobacco or coffee or something along those lines. And they already have this at-risk behavior for substance use disorder. It tends to be a little bit harder in that population. That's essentially what it's saying. They're just more prone to it based on their other conditions. All right. So obviously, in a perfect world, we want to use a combo of behavioral therapy and our medications. In reality, we may not necessarily have access to the behavioral aspect to that. So you all need to be prepared to do medication management for your tobacco users, right? And it doesn't matter if it's vaping, it doesn't matter if it's cigarettes, it doesn't matter if it's chewing tobacco. We all approach it the same. We're trying to, one, either replace that nicotine and slowly step you off of it, or we're trying to control the cravings in general and reduce the number of cravings that you're having. So if your patient doesn't want to do a pill every single day, you can definitely use nicotine replacement therapy. It's successful, it works. What I'll tell you is the patient can't be using their nicotine, so whatever that source happens to be, while they're on the replacement therapy. Because now all you've done is you've doubled or tripled the amount of nicotine that they have and made your life worse. So you have to tell them, like, hey, you need to stop the cigarettes, you need to stop the chewing tobacco while you're on this. And it's a set program. So you start them off at the higher dose depending on how much they're smoking, usually like 21 milligrams or 14 milligrams. And they wear that patch daily for a couple weeks. Then you step them down to 14 milligrams for a couple weeks. Then you step them down to 7 milligrams for a couple weeks. And by that point, they should be completely off of their long-term nicotine replacement therapy, right? And that's how you say, like, hey, it's no longer in your system. You're good to go. The short-acting stuff, that's like your gum and things like that. Once I get them down to kind of like that 7 milligram, 14 milligram, I'll throw that on. And that's like your situational, if you need it as a way to avoid the cigarettes, then we can use the gum or we can use the lotion just as a replacement for that. But eventually we need to stop that as well. Varicycline Chantix, they actually have these as blister packs now. It's the same concept. You start them off at their main dose, and then you're slowly bringing them down, slowly bringing them to a stable dose, and they're gonna continue that for 3 to 4 months, and that actually controls their cravings. The good thing about Chantix is they could actually be smoking or using their tobacco product when they start their Chantix, right? But within that first couple weeks, they need to completely stop that drug, stop their tobacco, and just be on their Chantix, and they carry on with that. So that's great about this one, is that they can be on the tobacco when you start the drug. With the Wellbutrin, the way this one works is it basically makes your tobacco taste nasty, and it's kind of more of that punitive effort. Does a little bit with the cravings, but with this one, they're supposed to be done with the tobacco when you initiate that Wellbutrin, right? Sometimes I'll try and get a 2-for-1 if they're also dealing with like an anxiety or mostly a depression or something like that. I'll use Wellbutrin just to see if I can also help them with the other without having to add on multiple drugs, right? But this one is a big one that I use quite a bit. I actually kind of tend to favor the nicotine replacement over the other drugs, just because patients kind of have a negative connotation towards varicycline and Wellbutrin. They kind of have that societal, like, oh, you think I'm crazy, I need to be on a drug. Whereas if you can hit them up with the patch or the lozenges, a lot of times they're a little bit more receptive to that. Worst case scenario, if you have a patient who wants to quit tobacco and you don't have any of these resources, you can still do it. You just go the old-fashioned way, right? So if I ask you, hey, how many packs in a day are you smoking? You tell me 1 pack. How many cigarettes in a pack? Do I have any smokers? Oh, don't do it. Do I have any smokers in here? 20? Right, cool. So there's 20 cigarettes in a pack, right? You're telling me you're smoking 1 pack per day? That's fine. So the way I go about that is, all right, you're gonna take 1 cigarette out of your pack, you're gonna crush it up, and you're gonna throw it away in the trash. So now you only have 19. So you're only allowed 19 cigarettes that day. And then over the course of a few weeks to months, I slowly take them off to where every week they get rid of another cigarette. So next week they have 18, next week they have 17, 16, all the way down. And you can wean them off their tobacco that way as well. So if you don't have these resources, you can definitely do it the old-fashioned way. This takes a little bit longer. It takes a little bit more willingness on the patient, right? But you can do it that as well. Good. So that's our tobacco. And that was a lot. Hold on. Oh, I know what that's talking about. Yeah. So that whole where they were saying like, oh, you can just convert over to an e-cigarette, it's going to reduce your tobacco use. That's not the case. You're just legitimately replacing one for the other. That was something that the tobacco companies did because they still need money. It's a big industry, and that's what they were doing. That's what it's talking about with that. That was a lot. Any questions about the substance use disorder categories? Right, so remember, they make the use disorder, it's all that 2 through 12 criteria, all is pretty much exactly the same. For y'all, when you're studying, try and focus on what makes the intoxicated state different and what makes the withdrawal state different for each of the drugs. And if it has a medication I can use, make sure you pay attention to that, because there's only a very few of them that have a med I can use to help with those scenarios, okay? Otherwise, that's all I have for today, and that's it, unless there's questions. Otherwise,